Hello, and welcome to the inaugural Weill Cornell Medicine Global Health Virtual Symposium. We are doing this to try to connect with colleagues around the world and talk about what Weill Cornell has done, what we plan to be doing in the future. We're going to start with some introductory remarks from Dr. Chelsea Clinton. Chelsea is a member of our Board of Fellows. That's the governing board of our medical school that reports up to the Board of Trustees of the university. She's also a member, the vice chair of our international committee of the Board of Fellows, so she's very involved with our international activities. And I'm pleased to turn it over to her for some pre-recorded remarks to welcome you to the symposium.
Good morning, good afternoon, good evening to everyone tuning in today. I'm so sorry we can't be gathered together in person, and yet I'm so excited and honored to welcome you to the inaugural Weill Cornell Medical Global Symposium. While I have the privilege of serving on the Weill Cornell Board and the International Affairs Committee, I'm also speaking today as a public health teacher, advocate, and certainly a very concerned citizen when I say how glad and how proud I am that this symposium is taking place and taking place right now. Public health isn't just a nice to have, it's fundamental to protecting lives, livelihoods, and enabling our shared future. But it fundamentally requires international cooperation and partnership, something that I know is keenly understood by everyone who is joining us today. And while there is so much we know about what works and so much we know about what doesn't, especially in moments of enormous stress and need, as we've seen over the last now almost 2 years, we also know how much more we have, how much more we need to learn together, to discover, to try, and to ultimately help establish what can work better and more equitably and more sustainably for everyone, everywhere. So I know you're as eager as I am to get this event underway. So again, I just want to say how grateful I am to everyone who has worked so hard to make this event possible, to everyone participating today, to everyone who's tuning in today, and ultimately to all of you for your shared commitment to improving health outcomes and helping ensure that more people have the chance, the opportunity, and the reality of leading healthy lives all over the world. I want to just now turn it over to those who will help kick us off, get us started. And I hope that we will all leave, and I really know we will all leave more inspired, invigorated, committed after the symposium than we were when we first tuned in. Thank you all so very much.
Hello again. Thank you, Chelsea, for those remarks. So my name is Michael Stewart. I am the Senior Associate Dean for International Affairs and Affiliations here at Weill Cornell. I'm also the Chairman of Otolaryngology Head and Neck Surgery, so I actually am an active clinician as well. And it's my pleasure to host this symposium this morning. We have several people from around the world connected with Weill Cornell and not connected with Weill Cornell to talk about international affairs and health education, research, et cetera. I'm going to start off by giving an overview of Weill Cornell Medicine's international activities. We have a very rich, proud history of international activities. I'm going to try to summarize those a bit here this morning to start off, and then we will move into a series of panels where we will discuss several aspects of past, present, and future related to international activities. We have an international affairs mission statement, which was adopted by the International Affairs Committee of our Board of Fellows. And this says, would be high because my, sorry. There it is. Our goals for international activities and global health are to improve health and education in the world, to extend and improve our brand and reputation, to provide opportunities for our students, trainees, and faculty, and to bring financial resources to the main campus. We don't have to achieve every single one of these goals with every single international collaboration, but this is the set of goals that our governing board has asked us to pursue and to address as we do international activities. And I think each one of our international activities hits on at least some of these themes. Again, I will leave some programs out here because I'm selecting the major ones that have been present for a long time and that involve a significant number of people. But we have several, and I've divided them into our major missions: research, education, and clinical. We have a Center for Global Health. This center does a remarkable job. You'll hear more about it from some members of the center this morning. This is a multidisciplinary center that works in several different continents, doing research, clinical care, and education, but primarily NIH-funded research, which is actually advanced global health. Gescio is connected with Weill Cornell. That's a clinic that treats HIV and tuberculosis in Haiti. You'll hear more about that. Our medical college branch in Qatar, which you'll learn a lot more about, also actually has a strong research portfolio, many millions of dollars of research funding, and many, many publications. And there's many other research initiatives that Weill Cornell has internationally. In terms of education, we have a robust international medical student education office. About 50% of graduating Weill Cornell students actually complete an international rotation. And we have many international students who rotate here. We, of course, have a branch of our medical school in Doha, Qatar, that's been present for more than 20 years. We give an undifferentiated Cornell University degree in Qatar. You'll learn more about that. For more than 25 years, we have worked with the American Austrian Foundation and the Open Medical Institute to sponsor the Weill Cornell in Salzburg seminars, which are education directed at clinicians who are out of training to try to improve health in the undeveloped, less developed parts of the world. And this program has evolved into a very rich, most weeks of the year educational program, and you'll learn more about that. We also do education at Weill Bugando Medical Center in Mwanza, Tanzania, for example. And we do clinical work internationally. A huge portion of this is with our partner hospital, New York Presbyterian, and you'll learn more about that in the upcoming panel. And that is both providing care for international patients when they come to New York City, but also collaborating with partners internationally around the world. In addition, we help provide clinical care at Hamad Medical Corporation and Sidra Medical Center, both in Doha, Qatar, both affiliates of Weill Cornell Medicine in Qatar, and both where we have Weill Cornell faculty providing clinical care and collaborating with our New York campus. This is a slide from Dr. Javed Sheikh. Dr. Sheikh is the dean of our medical school in Qatar. You'll meet him soon. And I was going to show this slide now so that we'll minimize the slides during the rest of the presentation. The original mission of the medical school there was to have a 6-year integrated program. Actually, the original mission was to have a pre-medical and a medical program where people got a pre-medical degree and then a Cornell University MD degree. It has evolved into a 6-year integrated program with separate admissions processes for the two programs. But over the last 20 years, this mission has really evolved. And remember this slide because Dr. Sheikh's going to be talking some about it, to include now activities before medical school. So there's foundational programs, there's high school outreach programs, and there's now a research program, which was actually not in place when the medical school was first founded. It was first founded only as an educational enterprise. There's now a rich research program, and you can see how many papers have been published. The institution has a nice H-index, and in fact, many of these papers are published in top journals. In addition to evolving to the pre-medical school aspect and evolving into research, it's significantly involved into postgraduate training and clinical care. We have helped both Hamad and Sidra with achieving ACGME international accreditation. We are also working very closely with the Ministry of Health to improve the local workforce, to improve the health of the population, to both study and improve the health of the population. And also, Dr. Sheikh has a great interest in global aspects of healthcare education, which we'll be asking him to speak on a little bit later on. There's actually lots of collaboration and development of scalable local models to improve health professions education around the world, all centered at our Qatar campus. These are some approximate numbers, and this map shows several of our major partnership locations. This is not every single one of our partnerships, but you can see we literally have partnerships on every continent except for Antarctica. And many of these are rich, long-standing partnerships. Some are primarily education, some are primarily clinical, some are primarily research, and some are all three. We have, out of our New York campus, a significant number of international publications. significant amount of grant funding that has been used for international research, significant numbers of patients treated, and students taught. We see our international office now and evolving into the future as having several different levels of collaboration. And we divided these into 4 different groups in kind of a pyramid, because the largest and broadest group is really at the bottom. Education and training is really the core of what we do. And we think that this is a model we can use for collaboration around the world. And this is comprehensive medical education programming for clinicians and trainees of all levels. We already have experience with this at many levels, and we think this is something that our new Office of International Affairs is very interested in collaborating around the world. We already do, and we're looking at expanding those collaborations. Our next level up would be consulting services. This is where we advise others on creating clinical programs, on creating facilities, on creating program management, on integrating education research into clinical care. But these would be programs run by others that we're simply advising or consulting on. And a level up from that would be a potential branded collaboration or affiliation. This would be something that would be a more significant level of collaboration and affiliation, where we would actually potentially use the Weill Cornell brand. But at the same time, we would be also leveraging our experience and our connections to help with research, education, or clinical care around the world. And then finally, a much more rare instance, but one we could potentially discuss, would be actually where Weill Cornell managed and or operated a facility for either education, clinical care, or research. That's obviously a much more complicated enterprise, but in fact, that is something that is potentially feasible with our Office of International Affairs. Now, I do want to spend a second talking about our International Affairs Office. This is the new office which we founded in the medical school almost 2 years ago, and the goal of it was to try to create an umbrella for all of our various international activities. As you will learn, we've had a significant amount of international activity over many decades at Weill Cornell, but each of these programs kind of existed with its own leader and in many ways somewhat isolated from the other programs. The goal of this office is to try to create an overarching office, not to change any of our existing programs, which are wonderful, but create a single point of contact, a single point of collaboration, and also in some ways kind of a database or a registry of all of our various international activities. So that anybody wants to know, can you list all the educational activities you have going on in Europe? We have a registry of all that. Our International Affairs Office is staffed by Monica Shaw, Ryan Lay, and Dr. James Pellegano, all of whom have significant international experience before joining our office here at Weill Cornell. Some of you may have been collaborating with them or hearing from them in terms of organizing the seminar. They have also, by the way, been invaluable in helping to organize this inaugural symposium. So thanks very much to Monica, Ryan, and Dr. Pellegano for all their help in putting this together. So that concludes my introductory remarks about Weill Cornell's perspectives on what our international office does and our perspectives on international healthcare. And I think in the interest of time, we will go ahead and move into our next panel. That'll give us some room for additional discussion and questions and along the way. So the way we've organized is that the next thing we're going to talk about is the New York Presbyterian Hospital's global patient experience. New York Presbyterian is our collaborator. They're our primary partner hospital. And we, of course, have worked very closely with them on our international clinical affairs. In fact, we decided many years ago that Weill Cornell Medical College was not going to form its own international patient care office. In fact, New York Presbyterian did. But since we're the physicians that staff New York Presbyterian Hospital Weill Cornell campus, they effectively are our international patient care arm. They've had for direct clinical care. They've had a very robust program which has grown over many years, and we're very pleased to have with us today two of the leaders from that program. Andrea D'Aquino, who's the Director of Operations and Business Development for Global Patient Services, and David Wyman, who is at New York Presbyterian, the Vice President of Regulatory Planning, Network Integration, and Global Services. So I've invited both Andre and David to join me here to discuss what New York Presbyterian has done over the years in their global patient experience. This started as a relatively small office with a couple of people and patient coordinators helping international patients when they came to New York, and actually grew to quite a large office, quite a sophisticated office that all along the way has integrated very closely with Weill, Cornell, and with the faculty here. So thank you, Andre, and thank you, David, for being here. And I've got several questions that I have sent to you and that I'd like you to discuss, but whichever of you would like to tackle, please describe for us just a brief history of the New York Presbyterian Global Services Program.
Good morning. Thank you for the introduction. I'm happy to start off. Global Services at New York Presbyterian is a very robust program. It started out in 1999, soon after the merger of New York Hospital and Presbyterian Hospital. As you indicated, it started with a very small number of individuals really facilitating international patients coming over to the United States for care. In the early years, patients were primarily coming from the Middle East and Latin America, and really building those relationships. We started out with regional coordinators that focused on particular areas. In the early 2000s, we began to grow into the Asian market. And really through business development, marketing, strategy, and really the use of analytics is when the programs really began to expand. And that was really in the early 2010 timeframe. The level of sophistication of the work that we were able to do to really facilitate complex care and bringing patients over is really what saw these programs grow over those years. We probably had our most successful years soon before the pandemic. Relationship building and facilitating, as you'll learn through this talk, is really what allowed us to build. The pandemic, as you can imagine, created significant problems for international travel across the board. So now we find ourselves really building back up. And again, we will talk about that a little bit more as we move forward. A very robust program that has grown from a small number of employees to over 30 at our high point. Everything from facilitating the financial aspects of care, information technology, coordinators, all patients are visited regularly, so we have a very robust team.
Thank you, David. How along the way did you decide where to go? It's a big world, and you can't go to every country. Not every country is necessarily interested in coming to New York. So, what were some of the decisions and thoughts that the institution had in deciding where and how to grow?
Good morning, Dr. Stewart. It's great to be here with you this morning. I'll tackle that one. So, as you can imagine, with a small number of resources at the beginning, we had to be very strategic in what we chose to do. And as David was saying earlier, there were a large number of patients that were coming to New York Presbyterian for care from the Middle East, Turkey, and Latin America. So we started developing relationships with physician partners abroad, with governments, with private institutions, basically, opening the doors of NYP to anyone who was interested in collaborating with us further. Not just on patient care, but as you, Dr. Stewart, were talking about education and training opportunities and other things that we do so well here at NYP. And frankly, we are so proud to be receiving patients from over 80 countries. Prior to the pandemic hitting us, we were receiving about 5,000 patients a year. So it really is a thriving department. And right now, as David was saying, we are rebuilding what we had accomplished so far, with still over the years having built very strong relationships and deep relationships in the Middle Eastern countries such as Saudi, Qatar, UAE, and Kuwait, and more closer to our hemisphere here in the Dominican Republic and Mexico, for example. So we really we had to be very strategic where we had to be, where we're going to be involved, again, because of resources. But frankly, we had developed some wonderful relationships around the world, and I know that we're going to be talking more about those a little bit later today as well.
Great. Thank you very much. So tell us what you've done during COVID. How have you changed? What do you not do that you used to do, and what's been your strategies?
Well, as you can imagine, COVID was a very, very difficult time, not only obviously for the whole world, but certainly as New York City became the epicenter, incredibly challenging to manage this line of business. Obviously, international travel stopped. So being flexible and innovative, we found different ways to assist patients. Obviously, being cognizant of international guidelines, New York City and New York State requirements for travel. We've begun exploring a number of technology opportunities for assisting patients internationally, and we're still working through many of those issues. Very complicated as you have international law in terms of liability. There's lots of complexity that goes into the ideas and the concepts behind telemedicine from an international perspective.
I do know that NYP has been a leader in telemedicine and in remote care for a variety of reasons. We've used that in our own network. We've used that to connect with some of our system hospitals that perhaps don't have some of the subspecialty. So instead of sending the patient, they do a teleconsult with the mothership that assists in addition to having robust second opinion platform and consultation directly with patients and international follow-up, et cetera, et cetera. So we've been a hospital together with the medical schools actually been quite proactive in that area. But you brought this up, David. I'd like you to elaborate on that. What are some of the challenges internationally? Because it seems natural, right? When you're dealing with such long distances, why don't you do these things internationally? But in fact, of course, there are some significant barriers.
So there are barriers. They can all be evaluated and tackled. The problem is it's really country by country. So what we've seen is the rules and regulations vary obviously by region and by country. So in order to engage in this line of business, particularly from the telehealth perspective, you really need to evaluate the rules and regulations in each individual country. So if you have existing and well-established relationships, that obviously makes the most sense to handle it that way. But if you're evaluating patients on an individual basis, as opportunities arise for care, that makes it much more complicated. So it's a very thoughtful, managed process in order to evaluate which countries and which market you want to go into.
Yes. Andre, do you have something to add there?
Yeah, and I just wanted to add to some of the things that David was saying, that during COVID, obviously, after March 2020, everything changed here for us here in New York City. And around the world. And really, I cannot be more proud of the work that our team has done to come together, to rally, and to really be responsive to our patients. Because you can imagine that with the restrictions in travel, it's very difficult for folks to come to us for care. However, we did receive still a large number of patients, especially from the Middle East, that were coming to us from governments for extremely complex medical care. And I think that's a testimony to all of the great things that are done here at NYP, Columbia, and Cornell. And I think that it's just a wonderful teamwork that we were able to do and come together and explore different ways of assisting our patients while staying safe, protecting ourselves and protecting our patients during the height of this pandemic.
Yeah, thank you all. If we have time later, I'm going to talk a little bit about something we're starting in our international office here at Weill Cornell, which I've spoken to both of you all about, and that is we're exploring the concept of international second opinions and international telehealth. But as David said, a key factor here is if you've seen one country, you've seen one country. Each country has different rules about this, and one of the major issues has to do with licensure to practice. So our physicians are not licensed to practice in foreign countries. However, our physicians could do a consult with the physician who is licensed to practice in that country. And so we're not caring for the patient. We're simply having a professional conversation with the clinician who is caring for the patient. And so that is something that is feasible. Now, again, it has to be, it's best if it's an institution you already have a relationship with, if you already have done work in the country and there's clearly legal and other regulatory aspects you have to assess. But we think this is feasible, and we're very interested in moving in this direction because we think this is going to be part of the new world after COVID, is figuring out how to get over some of these barriers. But it's not going to be as simple as figuring out how to do telemedicine state to state. When you're dealing with international consultations and telehealth, it's clearly going to be somewhat complicated. So perhaps we'll have time to talk about that a little bit later in the morning. And by the way, for all our attendees, this is early. It's very early if you're on the central or western part of the United States, but we put our symposium at this time because we wanted to be able to capture our European audience in the afternoon, our Middle Eastern audience in the late afternoon, and our Asian audience in the early evening. So that's the reason we're starting at 7 in the morning Eastern time, is because we thought it would be most conducive to have the most international partners potentially be able to collaborate with us live. So how the way we're structured here, just so that everybody is aware, both medical schools, because Columbia University College of Physicians and Surgeons also has a partnership with New York Presbyterian. They work at the Columbia campus up in Washington Heights neighborhood in Manhattan, and they have a rich international program as well. And so actually, New York Presbyterian has 2 medical school faculty to pick from, but in both circumstances, the medical schools employ the physicians. We actually have practice plans that manage our practices. The hospital doesn't employ the physicians. So in a situation where the hospital employs all the physicians, or at least it's somewhat easier perhaps for the hospital to select the physician or to come up with an arrangement where they actually have a physician provide the care. Can you give us some insight into 2 things? First of all, how do you select the physicians when you get a request from internationally? And second of all, how have you worked with the practice plans to actually facilitate the fact that the physicians are employed by a different organization?
That's a great question, Dr. Stewart. Again, I think we go back to the blessing that we are affiliated with 2 top medical schools, and we just have so many wonderful physicians that work with us in every single specialty. So our department, our Global Patient Services Department, when we receive an inquiry from abroad, it kind of goes through a triage stage. We also have 2 medical directors that work with us in our department, one at Weill Cornell and one at Columbia, to evaluate these cases very thoroughly. As you can imagine, the cases that do come to us are quite complex, and they might need a multi-specialty approach, which is some of the great things that we do here. So the cases are screened to understand who would be the best physician, the best group of physicians to be involved. Many times the patient themselves or the government or the insurance are actually asking for a specific physician to go to. We will evaluate the case and understand, is this the correct physician? We will send that to this physician. Sometimes this physician will tell us, no, I'd rather have one of my colleagues see this patient who has more experience in this particular area. So I think, it's part of us working with the chiefs of the departments, both at Columbia and Cornell, and understanding all of the wonderful things that are being done for our patients to be more minimally invasive, especially now, and the administrators of the departments as well, so that we have kind of a seamless communication amongst us and to truly understand the plan of care for the patient and then propose that to the patient. We serve as kind of the hub, the funnel for all international patients that come to us, and we utilize Columbia and Cornell physicians equally in all areas. So it is just a wonderful thing to have these wonderful physicians, over 8,000 physicians that work with us.
Great, thanks. So basically, you rely on medical leadership, medical directors, chairs, chiefs of service to help guide when you don't have specific requests for a physician.
Absolutely, we sure do. And again, a lot of these cases, the wonderful thing about having medical directors is that they are kind of the quarterback also of the case, because a lot of different specialties might be involved in a case. So you do really need to have that quarterback for the case, and it is very important to do that for the patient experience. That is extremely, extremely important.
Thank you. Now, without obviously getting into any proprietary details, I would like you all to discuss how in general have you set charges? Is it based on usual and customary? Is it based on some national benchmarks? What's been the general methodology you've used to set charges for international patients? And how have you divided fees between the hospital lab, the physician professional fee, the hospital, overnight stay, et cetera? Just in general, what's been your methodology of how you've set that over the years? I can tell you from experience, it's actually a quite sophisticated, standardized process, but I think the group would be interested in hearing how New York Presbyterian has thought about that.
It is. Again, we go back to putting patients first and the patient experience, right? So, and basically the experience of the referring of the insurance company, the government, whoever may be sending or paying, who is the payer of for the patient care. So what we have done, basically the charge master for New York Presbyterian is the charge master. There are no separate charges for international patients. So we go by that. But we work hand in hand with the different departments and medical schools, the Columbia Doctors and Weill Cornell Physician Organization, so that we're able to obtain charges for professional fees. So that we're able to create, at the very beginning, a very accurate estimate of charges that goes to the patient so that he or she clearly understands, and it's a very transparent process where there's no surprises, that this is the required deposit for the care here at NYP. I think that I'm saying it very simplistically right now. Obviously, we are 3 organizations, but what we do is, we do have one global bill basically for the patient. We collect all the bills for the patient when the patient really has to make one payment, and we disperse that payment to people who have been involved in the care of that patient.
I can tell you, having been part of that for many years, even before I was in my current role with the International Affairs Office, this has actually been a very smooth process. Whenever you're dealing with money, funds flow, bills, charges, it can be contentious and even a little emotional sometimes. But in fact, NYP does a fantastic job of collecting the money and distributing it. And so, and keeping us up to date about what the accounts receivable are, what the various, states of things are, and it's actually worked very well. So even though it's a complicated model, the global billing and the division has worked quite well. I had one more question, which I forgot about. But so what do you see now as? I know what it was. To what degree are you, relatively speaking, are you now dealing directly with governments and embassies, and perhaps even insurance plans of countries, that kind of thing, versus dealing with patients willing to actually write the check to come, and how has that evolved over time?
Yeah, that's a great question, really. I have been involved in international patient care for over 20 years. And had we had this conversation 20 years ago, I would have told you that 80% of the folks coming to us would have been self-pay. Right now, 80% are sponsored by some type of government or have an insurance product that covers their care here in the United States. So that really has also shifted our strategy because the self-pay patient, although very important still, of course, only makes up about 20% of our total number of cases. So in the meantime, we are dealing with governments from around the world that sponsor the patients through letters of guarantee for the care. but also, especially in Latin America, and more recently now, an emerging market in China, for example, is the insurance market. The insurance market has really, over the last 20 years, taken a strong foothold in Latin America, to the point where actually we have managed care involved, and we are able to do some direct agreements with insurance providers, key insurance providers in certain countries, to help their patients and to be in network for their patients to come to NYP. So things really have changed over the last 2 decades, and we really had to adjust to those changes. But I think that it will continue, the insurance products will continue to stay strong, and there will always be some self-pay, of course, but I think that is also going to start to diminish.
Thank you. Now, in the past, I know we had some discussion beforehand about this, but I think it would be helpful for the group to hear. In the past, there were occasionally, they were rare, but there were circumstances where, in fact, New York Presbyterian and Weill, Cornell, or Columbia would agree to send a physician to a country to do a consultation covering travel expense and time away, et cetera. That's become much, much more rare. Can you tell us about the evolution of that and how you would ever make a decision to do something like that?
Sure. In the past, there has been requests from physicians or physicians of patients for us to go to the particular country to take care of a patient. Again, that is something that we didn't do very often, but in the building relationships sphere, I think that was important. It's becoming increasingly more difficult. And I think it's because one of the things here at NYP, we're really very focused on building our domestic footprint here and around New York City and the area. So taking physicians out from their practice is really challenging. And I'm sure David can talk to you more about that, as he deals a lot with that. But for us, really being able to deliver care here in New York Presbyterian, it's probably the best thing to do, because again, when you go to another country, you're not sure what the ORs look like, what the staff is going to be like exactly. So it also carries a certain level of risk, and frankly, it is a little bit challenging at times doing that.
And I would add, as we've all touched on, it's so much of what we do and what we're talking about is relationship building. So it may be with a government, it may be with an insurer, it may be the beginning of an individual or a family that wants to do something privately. As Andrea said, sending one provider over for one consultation would be incredibly complex. Clinical programs or a day a month or 2 days a month where programs are being established for care is a different scenario. But as Andrea said, a provider to do individual care, that is increasingly rare.
Yeah, thanks for those thoughts. I know that I have been invited to come to other countries and come and even operate. Would you please come and operate on my my son or my wife or whatever and do the surgery here in the country? And I basically invariably tell those patients, no, you don't just want me as a surgeon coming over there. I need my team around me. I want to do it in my operating room with where I know the equipment and I know the people. It's not just about having the person come. In fact, if you wanted that, I'd have to bring the whole team. That becomes logistically almost impossible. And not that it could never happen, but it really is very complicated. I think that the idea that going over for a consultation you could do, that's a very long run for something that could potentially be accomplished without actually traveling all the way there. But coming over to provide care, I think is a problem, and not that it could never happen, but really one of the reasons I'm able to provide great outcomes It's because I work in a great hospital and I have a great team. And so much care is multidisciplinary. So much care requires more than one clinician. So I think that is probably something that was present at one time. It's probably unlikely to be something that's happening a whole lot in the future. So either one of you want to tackle the question of how do you see the future? And what do you see as international healthcare and medical tourism? How is this going to evolve? And what is NYP thinking in terms of how it's going to position itself as COVID hopefully becomes an endemic like influenza that we don't have to change our lives about?
So we're certainly in the rebuilding phase, looking into the future. Clearly, we need to get back to where we were before, but I think everybody's feeling that and going through that. Certainly, as we touched on, digital health and telehealth. That is the way of the future. How that rolls out for the international market, as we talked about, it is evolving and will continue to evolve as the rules in and around digital health transform. We are putting tremendous resources into this. I think that's the way of the future. Andrea, anything else to that?
I think, countries around us are they're going to improve their outcomes. They're continuing to improve their outcomes. And I think it's important that they do, and it's part of our mission. Education and training is going to be extremely important going into the future. I see that international travel still will be here, of course, for extremely complex cases, and where we continue to be at the forefront of technology, forefront of leading medicine with our great physicians, nurses, and all the 48,000 strong that work here at NYP Enterprise, truly. So I agree with David. I do think that telehealth and digital health is going to be key and very important for us, and also to continue building relationships across the board.
Yeah, thanks. I think that given NYP's track record, I think that you will continue to be successful in the future, but it's going to be a different future. And I think, another way to think about this is in some ways as an institution that provides education, clinical care, and research, our goal should be almost to put ourselves out of business, because wouldn't it be wonderful if no one needed to travel anywhere for healthcare? Now, we're a long way from that, but in fact, that should, in some ways, be our goal. And I think that's you'll hear from Professor Wolfgang Alitzky later. But in fact, one of the goals should be not having everyone have to rely on traveling to get healthcare. What we want to do is raise the level of education, et cetera, in everywhere, so that in fact there's better healthcare around the world. And if in fact that results in fewer people having to travel here, well, that would be a good outcome. That would be good for the world. So I think it's fun to be part of this trajectory and see a change. And we've absolutely seen a change. As Andrea said, there are many circumstances now when we get asked when we, outside of the hospital, get asked by our colleagues around the world, what would you do? We say, we do this. They say, okay, we can do that. And they have the tools, the technology, the training to be able to do what 20 years ago they would have had to transfer the patient to perhaps not necessarily the United States, but perhaps to another country to be able to get that level of care. And it really is evolving around the world, which is great to see. And it's nice to be part of that. So,
and just to add to what you're saying, Dr. Stewart, it's just you're saying, for example, 20 years ago, I used to work down in Texas and Houston, the Texas Medical Center. We used to receive a large number of cardiac patients who used to come up for a heart cath or a simple angioplasty. Nowadays, you will not see them because medicine in Mexico and other countries has really evolved. Fantastic physicians that we work with abroad, and the facilities are also fantastic. So again, you're shifting into other types of where technology is going to be even more important for us to be at the forefront. So I completely agree with what you're saying.
So one more question for the two of you, and that is, there are probably some people watching this that are perhaps in an earlier stage in their development. They're interested in developing an international program at their hospital or their practice plan or wherever they might be. Now that we have a long track record here of seeing this evolve, what would you advise someone starting out? What are the first steps? How do you get started in this? What do you need to put in place, and what are some lessons learned along the way that could help somebody?
Well, I would think that, an international program is something that isn't to be taken lightly. I think you need to have leadership buy-in, and I think you need to have leadership support, senior leadership support. So it is very important that you do not operate in a vacuum, but that you really are part of the strategy of the hospital. Again, here for NYP, the wonderful work that we do with Weill, Cornell, and Columbia, I think there's always going to be a need for an international program. But it is very important that we're able to be backed up by senior leadership. That's definitely one of the things that I think is important.
And I would like to add, obviously, we talked about education and the goal that no one should need to travel for healthcare. As that is evolving, programs looking at the services that they're providing. What countries require certain types of care. So I think that's also incredibly important. And at the end of the day, relationship building, as Andrea said, support from leadership, and it needs to be a commitment from the entire organization in order to have something like this be successful. This is not to be taken lightly. There are lots of complexities with bringing patients in from other countries internationally. Lots of things to think about. So it's important that everybody's on board, all hands on deck, so to speak.
So thanks very much for those thoughts. The things I would potentially add, having seen successful programs both here and actually also coincidentally enough in the Texas Medical Center where I also was about 20 years ago, they did a fantastic job at some of the institutions there dealing with Latin America. That's a natural connection. There's lots of nonstop flights. So they took advantage of some of the geography, the natural connections. And they took advantage, frankly, of tourism. A lot of people from Latin America actually like to come to cities like Houston and Miami and others where they can get a nonstop flight, where they can go shopping, where they can take a little vacation. Oh, and by the way, get some health care. So there's actually more to this than just arranging to take care of the patient when they show up at the admissions office. There's thinking about their travel, there's thinking about translation, there's thinking about sort of concierge services, helping them get around, figuring out what their needs are. Are they actually planning to come for a few days before they come for the healthcare visit, or is this entirely around the healthcare visit, et cetera? And I think that a successful program has to take all those things into account. What are some natural connections? What are the patients going to want to do also while they're there? How do we take care of how do you help take care of the family while the patient is hospitalized? There's also some pretty significant cultural differences to keep in mind. I learned early on that American patients don't want to be in the hospital. I can have this as an outpatient, right? I don't have to stay in the hospital, and so it's an advantage if you can do this and let them go sleep in their own bed. I had international patients say to me, so what would happen after the surgery? I said, well, we would send you home. And they would say to me, well, doctor, don't you care about me? You're just going to send me home? You're not going to keep me in the hospital and watch me? So it was actually, in some cultures, it was considered poor quality in some ways to actually send the patient. They wanted to be in a hospital being monitored. And so, in fact, we would then take into account that the patient who would come for a procedure was going to be in the hospital being monitored. And actually, that makes a lot of sense because they're not at home. They'd be going to a hotel. They wouldn't have their family support, et cetera, around them. So you have to think about that in a different way than if you're in your home country and you can go home and you know how to take care of everything when you're there. So plus there's just some cultural differences in how people consider inpatient, outpatient care, how people want their pain managed, things like that. So there's a lot that goes into this in addition to simply providing healthcare expertise. And I think if you're thinking about getting involved in international healthcare, these are all the things behind the scenes you have to think about. And I also think, as you heard earlier, this is really evolving now to governments, embassies, insurance plans, et cetera. This is less about connecting with a patient with a desire, and it's more about connecting with a system where, in fact, they might, those are the sort of relationships that you're going to have to build to be successful in the future. So any closing thoughts, Andrea or David, on this topic of NYP's global services journey?
I think, we hit some very key points. The international market is certainly evolving. COVID and the pandemic is changing the landscape. And as you indicated, certainly going from sort of the individual need to the more formalized relationship, whether it's through a government or an insurer. And I think very, very interesting topics. And this morning's, or not this morning for some of you, but a wonderful presentation ahead of you.
I agree with David, and also want to say that for all of you following us around the world, we'd be happy to answer some questions and write to us. I'd be happy to offline to then talk further about the things that we do here at the New York Presbyterian Global Patient Services, if there are any further specific questions. So it's really been a pleasure, Dr. Stewart.
Thank you all both for being here. And I think in the interest of being sure we have enough time for continued discussion and some question and answers from our audience, we'll go ahead and close this panel and move to our next one a little bit ahead of schedule. So thank you all again, Andrea and David, very much for being here and for sharing your Presbyterian's experience and your own expertise in this area. Thank you.
Thank you.
Hello, welcome back. It's my pleasure to have some other panelists join us here from Weill Cornell. I'll introduce them in just a moment. Please, we're going to be to the audience. We will be having a question and answer session after this. So please be thinking of questions and answers, and put those in the Q&A portion. And we'll be happy to try to organize those questions and take them. So be thinking about any questions you have and pose those to us. So this next panel is going to be on international collaboration's current issues. And we have three panelists joining me here. We have Professor Wolfgang Alitski. Professor Alitski is a urologist. He is the medical director and the founder of the Weill Cornell in Salzburg seminars, which actually is it's become larger than Weill Cornell in Salzburg, as he will describe to you. It's now branded under the name the Open Medical Institute, and it's actually expanded even outside of Salzburg, in addition to expanding outside of Weill Cornell. So he has a tremendous amount of international experience with education and with clinical care. And so it's a pleasure to have you with us, joining us, Wolfgang. Thank you for being here. And then we have two members from the Weill Cornell Center for Global Health. I mentioned briefly early in the introductory remarks, the Center for Global Health is one of those centers that started relatively small in one division, has become a very large multidisciplinary center with multiple clinicians and researchers and educators from multiple departments and divisions at Weill Cornell. It actually operates in different countries and does research, education, and clinical care. And we'll be hearing about the Center for Global Health from its director, Dr. Dan Fitzgerald, who took over from the founding director, Dr. Warren Johnson, a few years ago. Dan is also a professor in the Department of Medicine. And we'll also be hearing from Dr. Jennifer Downs, who's a member of the Center for Global Health, senior member, and an associate professor of medicine here at Weill Cornell. So Dan and Jennifer, thank you for being part of our panel this morning. I'm going to start off by asking Wolfgang to just give the group a brief introduction, give the audience a brief introduction to the Open Medical Institute, the Salzburg seminars, and what's happened over the last 25 years and where we are now. So Wolfgang?
Well, thank you for having me. I'm sitting in a hotel room in New York so that I'm within your time zone. And I'm glad to introduce the Open Medical Institute to you, because whenever programs like that are initiated, there is a history behind this. The history behind the Open Medical Institute was were the major political changes in Europe taking place after the fall of the Iron Curtain. Suddenly, a whole world was open to us in the West, and we realized, we as physicians, that the level of healthcare in the formerly communistic countries was really not in good shape. And it was a group of physicians at Weill Cornell and in Austria who decided to take action. And we organized the first seminar in 1993. And we were looking for an attractive location, so we decided to run the first seminar in Salzburg in the Sound of Music Castle, Leopoldsgrund. It was a big success, and we realized that knowledge transfer is important, but that is not enough. Because at the same time, when we had a chance to look into the Eastern European countries, the borders were suddenly open, and there was a tremendous wave of migration of healthcare professionals. So we realized that there were two major issues that needed some kind of improvement. On one hand, brain drain, and on the other hand, this lack of knowledge, lack of experience with modern medical technologies, treatment protocols. And that's why we decided to organize an educational pyramid, a pyramid which provides knowledge transfer through seminars, experience exchange, mainly through observerships and fellowships. Finally, the electronic publication of the content. So we created a free source for the physicians in Central and Eastern Europe and Central Asia, which was continuously updated. So in other words, we created an electronic handbook. Since 1993, we have now organized 730 seminars, and we have trained almost 25,000 physicians. And throughout the course of the establishing of this program, we also learned that we need to continue providing not only knowledge, experience exchange, but we must not stop this program. Because if we cannot help the physicians in these countries, and these countries are unable to grow, not only in terms of healthcare, because healthcare is important for a whole society to grow, then we can't grow. And therefore, we are now continuing this program with the fourth level in this pyramid, and the fourth level is our leadership program. So in other words, we provide qualified young physicians from countries in transition or countries in need, knowledge, updated knowledge. We provide them the possibility to get experience and share their experience with outstanding experts from universities and hospitals in the West. But we also help to build local capacity. And finally, if somebody is interested in becoming a leader in this country, we offer the leadership program. But there is another important caveat with this program. We do everything we can. We mentor our colleagues and physicians in these countries, but we want them to stay in their home countries. Because again, if they leave, which is still happening with large numbers, we will not be able to stem the brain drain. And without qualified experts, without qualified colleagues in the countries, neither the healthcare system nor the societies can grow. So it is a major philanthropic effort, but the leadership of Weill Cornell at the very, very beginning, and still Weill Cornell is actually the main academic supporter of this program. Without this help, we wouldn't be where we are today. So I hope this gave you an overview about the Open Medical Institute, and it is ongoing right now. We provide every year 40 seminars in all important areas of medicine for people literally from around the world. And we also realized that the situation that we found out in Central and Eastern Europe and Central Asia is exactly the same in Latin America, because there are some outstanding institutions, but not for the majority of Mexico, from other Latin American countries who migrate to the United States. So we have the same brain drain issues in this part of the world. And therefore we have to find ways to train and educate physicians locally. And we also have to find a way to build local capacity. We have to stem this brain drain, because we cannot steal all the good brains around the world and ask them to work here. And this is the main aim of the Open Medical Institute.
Great. Thank you, Wolfgang. One other quick couple of comments. The Open Medical Institute and the American Austrian Foundation are supported almost entirely by philanthropy. So these efforts are actually philanthropic, and it's actually quite remarkable that the Foundation and the Open Medical Institute have been able to continue to raise money to support this initiative over many years. And also, I should point out that Dr. Alitsky is the Associate Dean of International Learning and Distance Learning for Weill Cornell. So he's based in Austria, but he is the medical director of these seminars, the Open Medical Institute, and also is an Associate Dean at Weill Cornell. So thank you, Wolfgang. I'll turn it over now to Dr. Fitzgerald to talk to us about GESCIO, the Center for Global Health, and international activities associated with that program. Dan.
Thank you, Mickey. So the Center for Global Health is located within the Department of Medicine, but has collaborations with multiple other departments, pediatrics, OBGYN, multiple surgical subspecialties. microbiology and immunology. So we are multidisciplinary center. Our focus is really on health equity and working in lower income countries to assure people the right to health. We view that healthcare is a human right, and our role is to work in partnership in lower income countries to try and secure that human right for in the countries and with the populations where we work. Some sort of the characteristics of the partnerships that our center in New York has internationally. Again, they're in lower income countries, Haiti, Tanzania, Uganda, and they're co-equal partnerships. So there's an institution in the host country. These are generally healthcare institutions or academic institutions who are providing care to underserved populations and people who cannot afford healthcare. So we partner with those institutions and then really view it as a co-equal partnership where we're learning from our partners in Haiti or Tanzania. We're learning from them about their views on healthcare, how they provide healthcare in these challenging situations. And then we hope that we're sharing technical capacity and medical education to our partners. And the training activities are bidirectional, where we have people go down to Haiti or travel over to Tanzania. And then we receive trainees here in New York who may be training in clinical services or maybe training in research methods or laboratory methods. So it's a bidirectional training. All of our programs internationally have a component of research, clinical care, and training. The research is really trying to find solutions for healthcare problems in the countries where we work. And our research is really predominantly clinical research and what's called implementation research of how do we get care to people in the most effective way. And again, that's often, there's learning back and forth between institutions. We may be able to provide some more technical laboratory support for a country like Haiti, but the team in Haiti has amazing community health workers and amazing public health systems that they have developed to work under some of the most difficult situations. And frankly, I thought we were a little bit learning from the rest of the world during the COVID crisis and how to do contact tracing, how to set up rapid testing facilities. So again, there's this bidirectional learning that happens. The partnerships that we have are relatively few. We don't have 50 partners around the world. Rather, we try to have, we have 4 or 5 partners and internationally, but these are decades-long partnership where we're really, as Wolfgang mentioned, we're really striving to build capacity locally with our partners. And the number one for building capacity is people and young people and training young clinicians and physicians and nurses. And so train people takes time, and to train a medical student and then who becomes a resident and then becomes a fellow, that takes decades. And so our partnerships in the countries where we work, the Haiti program started in the late 1970s, while Bugando in Tanzania started in 2003. So these are places where we move in. Also, sort of I think a unique characteristic is we have on-site faculty in the countries where we work. So Weill Cornell faculty actually have joint appointments in the host institution. So For example, in Tanzania, Dr. Robert Peck, who's trained in medicine and pediatrics, has lived in Tanzania and raised his family and has been there since 2006. And he's an associate professor of medicine and pediatrics here at Weill Cornell, but he's located internationally. As a way of example, we thought that I work in Haiti, and so the Haiti program began in the late 1970s when Dr. John Pop, who grew up in Haiti, is Haitian. He went to medical school at Weill Cornell, graduated residency at New York Presbyterian, and then in internal medicine, and then wanted to return home. So he returned to Haiti in the late 1970s, 1980, was working on childhood diarrhea and introducing oral rehydration fluid. He was receiving technical support and assistance and financial support from Weill Cornell to be down and working on this issue. He was working at the General Hospital of Haiti and was setting up a childhood diarrheal unit when he kept getting called down the hallway to the adult wards because they were seeing patients who were dying from diarrhea and sort of bizarre opportunistic infections. He also had a friend who was a dermatologist and noted that a lot of these young people who were dying from diarrhea had Kaposi's sarcomas, and these were the initial cases of AIDS in Haiti. That when the CDC reported the cases from California, they recognized that they were seeing the same thing in Haiti. So Dr. Pop and a group of Haitian colleagues established GESCIO, which is a Haitian acronym for the Haitian Group for the Study of Kaposi's Sarcomas and Opportunistic Infections. And that is now a large Haitian nonprofit organization, provides care to tens of thousands of people with HIV and tuberculosis, conducts NIH-funded research on optimizing care for HIV and tuberculosis, and provides education to healthcare workers throughout the country in the provision of care. And there has been support from Weill Cornell for GESCIO, helping them develop the latest technologies. And we've learned a lot from GESCIO. Many of the standards of care and systems to provide HIV care in Haiti were subsequently adopted in New York. So Haiti developed a community-based program to rapidly initiate people who were diagnosed with HIV on care and to start their antiviral drugs on the same day that they were diagnosed. That model of care was adopted and recommended by the World Health Organization. And then about 5 years after Haiti had adopted it, New York State has recently adopted it. And so, again, we can learn bidirectionally. And then I'll introduce my colleague, Dr. Jennifer Downs, who works at Weill Bugando in Tanzania. And perhaps Jennifer can describe Weill Cornell's work in Tanzania.
Thank you, Dan. Yes, I'd be happy to do that. I think that the work at Weill Bugando in Tanzania shows some of these same principles that you were laying out that are the real goals of the Center for Global Health. It's a partnership with an academic medical institution at the site. Years, decades of collaboration and kind of locally driven leadership and seeing that capacity grow over the years. And then expanding. So at Weill Bugando in Mwanza, Tanzania, even since the early 1990s, there was sort of a recognized need by the local community there of a need for a medical school in Western Tanzania. It was something envisioned by religious leaders, medical leaders, even the community in Western Tanzania. And in that area of the country, Tanzania only had one physician for every 50,000 people. So at that time, Weill Cornell alumnus, Father Dr. Peter Lejac, was working as a physician in Mwanza. And together, these local partners reached out to him for some assistance with fundraising and starting to think about the curriculum for this new medical school that they wanted to develop. So that relationship began, and the medical school was officially opened in 2003. And that it was affiliated with the tertiary hospital there that provides care for about now 16 million people in the region. So when the Weill Bugando School of Medicine originally opened, they started with 10 students in the first graduating class. That has grown to the point that now classes are about 200 students per year. And there was just graduation this past weekend in Mwanza. At this point, Weill Bugando School of Medicine has graduated over 1,600 MDs. Most of these students stay near to Mwanza and provide care where it is so desperately needed. In addition, the school has expanded to offer other programs. The residency training programs have been strengthened, and there have now been over 300 residents trained in internal medicine, pediatrics, gynecology, obstetrics and gynecology, and surgery, and then increasing other programs, including master's and PhD training. All of this with this goal of building capacity and working with our local partners through the Weill Bugando School of Medicine. And really a cardinal feature of this program has been the bilateral exchange that Dan was describing, where we have trainees and faculty members going in both directions between Mwanza and New York. And we really strive for partnerships where each is learning and contributing together, and that makes us so much stronger than as a whole than the sum of our parts. In the past, I first went as a resident in 2007, and it has been so rewarding and exciting to see some of the residents that were there training at Weill Bugando School of Medicine. They were also residents at that time, now becoming the junior and mid-career faculty who are leading the way and leading the medical school, and are still these tremendous colleagues that I learned so much from. And then there are growing research collaborations. At this point now, the program has multiple NIH-funded research grants and training grants. And it is such an exciting time to see the program continuing to grow and capacity continue to expand in Mwanza.
Thank you very much, Dan and Jennifer, for that great introduction to the background behind those programs, which are now very, very well established. All of these are well-established programs in different continents, serving different but related goals, and all of which have very strong connections to the mothership here in New York, but also have these bilateral connections, which are so important. So the questions I want to focus on now that the attendees have learned a bit more about these programs is, how have you been handling the current situation? What's been happening during COVID? What has changed? What have you had to stop? What are you doing that's new, et cetera? So we'll start with Wolfgang. Wolfgang, what of the Open Medical Institute, what did you do during COVID?
Well, first of all, we included COVID-related state-of-the-art lectures in all of our seminars. And at the beginning, we still ran seminars in 2020, but then we had the lockdown. And I don't know, would you like now to know how we responded to this lockdown situation in terms of our program? Okay. Yes. Well, we wanted to continue because we thought it is important to continue this educational effort. And therefore, well, we had to switch from on-site seminars, where we usually have between 150 and for clinical seminars 300 applicants, and then we select 32 to 36. They could not come anymore, so we switched to an electronic version, and we started the so-called Ominars. And I think it helped, but it is not an ideal way to educate, in particular when the alternative is a dynamic American or Western trained physician who really believes in Anglo-Saxon didactics. He is really attracting the fellows. This is something you cannot get across through a webinar, because the seminars are nothing else but webinars, because you cannot even establish eye contact. So it is sort of a distant educational method, but at least we could cover all of the seminar topics in that difficult lockdown period. And to our big surprise, the people reacted quite positively to this. So in other words, we ran, instead of seminars, 28 ominars, and we had more than 1,000 applicants. And but now we are back to regular seminars, and to a certain extent, we re-invite those ominar participants, but we are now back to normality. We also tried to provide relevant information to our fellows. For example, the keynote speaker at our last benefit, which is now published on our webpage, was Anthony Fauci, and he gave a very comprehensive but very hopeful overview about the COVID situation, and that the vaccines will help us to overcome that problem. We also provided financial and equipment support to some of our partner institutions who were in real need. Together with the Open Society Foundations, which is also 4 centers of excellence in Central and Eastern Europe, and provided funds for buying protective equipment, and also to buy electronic equipment for education in order to disseminate information. One of the largest program that we got involved in terms of COVID is related to Kyrgyzstan, and that's actually where I also provided some slides, but $1,000 grant, so that they could establish a school educating the healthcare professionals in 3 out of the 7 provinces of Kyrgyzstan, and educate them with all COVID-related topics. They could also use the money to buy medication, for example, dexamethasone, which was at that time the only drug that seems to be somehow beneficial. But it was mainly, again, protective materials that they purchased. But most importantly, they trained more than 600 healthcare professionals in Kyrgyzstan, which made a major difference, because Kyrgyzstan was one of those countries hit hard by this COVID-19 pandemic. And the people were not prepared, just they were not prepared in our countries at that. So this education effort was quite helpful. So in other words, we were trying to help where we were asked for help, but in many different ways, not only education, but also money, educational support, of course, and also to a certain extent, because it is a very complex situation in these countries, with ongoing advice by experts. So this was our response.
Thank you, Wolfgang. So Dan, same question to you. What did you change during COVID, and how did you manage to keep programs going? What did you have to evolve, et cetera?
Just follow up one thing that Wolfgang mentioned, and I think shows the strength of his program. You know, the time to prepare for emergencies is before the emergency, and building those relationships and the trusting relationships and building the capacity on the ground, that it really pays dividends when an emergency situation happens, because you have the trust, you have lines of communication, you've worked together with people, you know them, so that when there's a pandemic, there's channels already there to communicate and to act. So in Haiti, I'll talk about Haiti, and I'll let Jennifer talk about Weill Bagando. But in Haiti, Weill Cornell really played a robust role, in partnership with Geskio and the team down there in the response to COVID in Haiti. Dr. Pop, who's a professor, was the founder of Geskio and a professor here at Weill Cornell, was actually named by the president of Haiti to be the co-director of a national response team to the pandemic, and was really critical in establishing COVID testing, setting public health guidelines that were responsive and understanding that when people are living on less than $1 a day, you can't tell them to stay at home, by trying to come up with preventive guidelines that allowed people to continue to live. Also set up treatment centers across the country, and was really sort of playing a national leadership role in the country. Vanessa Rousier, who from Weill Cornell was really managed the clinical and worked at the clinical facilities at Geskio. So Geskio itself ran 2 inpatient units, and she really led that and actually wrote a nice article in the New England Journal of Medicine describing how lower income countries could marshal the internal resources to respond to COVID. So I think the sort of lesson learned was just the benefits of establishing relationships and local partnerships pays off in these situations, in these horrible situations, in emergency situations, because you have teams down there. And then from New York, we were really able to provide them financial support and material support, and technical support. So had microbiologists that were helping them establish the COVID testing, had teams in the US who were able to sequence COVID genomes so that they could be tracking what variants were hitting Haiti and when, and really were able to anticipate the Delta surge, because we started seeing the Delta variant peaking up in the spring, and knew that so they were able to sound the alarm publicly and set up treatment centers before the wave. So I think there was a great response. I'd say from my perspective, the single greatest challenge that we faced, and really continue to face, is the lack of vaccine equity with our partner sites. It's we're striving for equitable partnerships with our colleagues, and that we're working hand in hand to promote health equity. But then many of our colleagues, our healthcare professionals overseas, were not able to get vaccines, but they were still on the front line providing care for patients with COVID. And we were not able to get them vaccines. And that was really heartbreaking. And we're both Weill Bugando and Weill Cornell and our other sites are now taking the lead they have secured some vaccines and are now taking the lead in vaccinating in their countries. But that gap of about 6 months was very hard. Maybe Jennifer can talk about Tanzania.
Yes, thanks. A lot of the similar things that both Wolfgang and Dan have said, kind of adapting to using technology to share information. Because the wave of the pandemic hit New York sooner, there was at least a little bit of experience that we were able to work with our colleagues at Weill Bugando to plan ahead, to start to make protocols for how we would be managing patients. And then the other thing I would add is that it has continued to be a learning experience and a partnership, working with our colleagues on the ground to define the questions and think about how we can address the problems. So Tanzania faced some of the similar challenges with perceptions of COVID, what people's willingness or ability to comply with guidelines, lack of understanding and difficulty sharing accurate public health messages. And in partnership with our colleagues, we used the platform we had established for a different public health project. And we're able to address sharing public health information and some basic community teaching about COVID-19. So we have several projects now working with religious leaders in and around Mwanza, Tanzania. They are highly trusted and respected in their communities. Some people have said even more so than physicians. And our local partners really advised us and said to us, these would be the people to help us share correct information about COVID in rural communities. And so we were able to get some additional funds to support work in which we provided accurate public health messages to some of these respected community leaders, and they in turn shared information and masks with people in very rural Tanzania. And back to the theme of these building on the established partnerships and learning from colleagues. Because of that, we were able to share information with about 100,000 people, very rural, wouldn't have had access to these sort of things, didn't have access to masks, and helping them understand when is it that you need to seek medical care, how can you prevent COVID-19, and we are now hoping to build on that platform, again, to work towards more vaccine uptake in the country.
Thanks very much for that. I think a couple things. One is that it also is true, you should correct me if I'm wrong, but in addition to all the extra things that everyone did during COVID, some of the core missions continued. You continued having online seminars in education, and you continued, Geskio stayed open now. They may have, changed its mission a little bit. The medical school kept training its students, at Bugando. So every one of you managed to keep your core programs at least going at some level. And in addition, you pivoted and used resources to help with COVID and to help with the changing situation, which is really quite admirable. Your responses have led me to jump ahead to a question that I was going to ask you all later, but I'll just go ahead and ask you now. And that is, since these international partnerships are so important, how do you assess an international partner? How do you decide who's a good partner, who's a bad partner? And what are some tips you might give for people who don't have as many long-standing international partnerships? How to get started and how to make the assessment. And I'll ask every one of you, but we'll start this time with Jen in terms of how to assess international partners and how to establish these kind of relationships.
Mm-hmm. Thank you. I would say that we look for, first and foremost, partners that have kind of a long-term commitment to these shared goals of building capacity and improving health in their communities. And you can see that in a track record of people that have been committed to training, committed to conducting research that affects and improves the health and the health equity of the poor people in their communities. And not only in their communities, we look for partners that also are doing work that's translatable beyond and might have implications for other poor regions around the world. Second, I would say partners that have commitment to training junior investigators. That is a time-consuming commitment, but really pays dividends, and I think is worth kind of that initial period of growth for the benefits it reaps for the community later. And finally, I would say we value partners that have a commitment to training women. Women are uniquely able to address some global health goals and some health issues in ways that only training men will frankly leave unaddressed or incompletely addressed. So partners that have women and are pursuing training and equitable opportunities for women are also something that we value greatly and work together towards. I think this is a challenge not only in poor countries, but in much of the world. So that's I'd say another shared goal.
Thank you, Jen. Dan, your thoughts on that?
Just to add on what Jennifer said, I think another feature is looking for an organization that has good links to the community and good, that it's not an isolated single institution, but rather an institution that's either a public institution or is a nonprofit organization that has very good community outreach, and building those ties, which we've really found essential. As Jennifer said, she's worked a lot with religious leaders of all denomination and faiths. And so I think a lot of the organizations that we've worked with have those community ties. They're very, Jeskio, for example, is very, has a strong community advisory board, has people in the community who know Jeskio. When you're around in Port-au-Prince and walking around, if you have your Jeskio bag, John, people will stop you and say, "Oh, thank you, Jeskio." They know the organization, and it's a Haitian organization. People are very proud of that organization, and so those community ties, I think, are really essential. And the commitment to health equity of providing care for everybody.
Thank you, Dan. Wolfgang, you certainly have, from starting with one seminar that was Weill Cornell to 40 seminars now with multiple academic partners and partnerships all around the world. What are some of your tips in terms of assessing and establishing partnerships and how to be successful in that arena?
Well, I think I really have to say that I'm admiring what Weill Cornell is doing in Haiti and what Weill Cornell has done in Tanzania, because we, as an educational organization, we benefit from that. And for example, this reminds me of the new medical director and chief of urology at the new hospital in Dodoma, which is the new capital of Tanzania. He was a resident at Weill Bugando, and now he is chief. And that brings me to the answer that I would like to give. I think institutions are very important, but people are much more important, because we have to deal with difficult political situations which can change from one day to another. Institutions are in or out. The cultural differences are sometimes remarkable. And this is something that we, coming from the West with our Western thinking, only sometimes are having difficulties to deal with that. For example, women's issues. A female urologist in Central Asia, which is a fairly developed country, in Kazakhstan, for example, she was only allowed to diagnose X-rays or evaluate X-rays. She was not allowed as a woman to touch male patients in Kazakhstan 2 or 3 years ago. So the cultural issues also play a role, and therefore it is the sensitivity of people on site who work locally to make the right decisions. We, in terms of education, we are sort of in a privileged situation, because we invite the people out of their country to come to us and meet with other people in a similar situation. Usually, as you know, we have participants from 22 to 28 different countries. In some of the countries, the difficulties are similar, in some there are others. But again, I want to give you a practical example. We just established a close collaboration with Black Lions Hospital in Addis Ababa. It was possible due to the political change taking place 3 years ago. Now, when Ethiopia is drifting into a new civil war, it may change again. And therefore, we have to adapt. So therefore, the Open Medical Institute is almost exclusively focusing on individuals, on colleagues. And we do everything. We mentor them as much as we can so that they can build a career back home. And ideally, of course, these people get involved. These people take on leadership positions, or they build a similar organization as we are. And that is, of course, an ideal scenario. And I can show you a couple of examples. And in the second or in one of the next sessions, I would like to show you what we have achieved, for example, in Kyrgyzstan. But also in Mongolia, we have trained about 7% of all Mongolian physicians. And out of those approximately 500 OMI fellows, 98 of these colleagues are today in leadership positions. They run departments, they run universities, they are in leadership positions at the Ministry of Health. And that is, it's a slow process, but that in the end helps to change the situation locally. Because in my view, a change can only be successful when it happens on site. And that's why I'm so impressed by the activities of Weill Cornell in Tanzania and also in Haiti. It is really, I congratulate both of you that you are so heavily involved with this and successful.
You know, there is an interesting common thread which comes to mind here. We didn't mention it before in doing the introduction, but Dr. Alitsky did his fellowship. He trained in Austria. He did his fellowship here at Cornell and at Memorial Sloan Kettering. He gained access to the Weill Cornell culture during some years here, and then wanted to sort of use that in his collaboration. Obviously, we heard about Dr. Lejac and we heard about Dr. Pop, both who had a connection. And so it did start with people and a connection and good people who wanted to do the right thing. And those people and those connections have persevered over all kinds of changing dynamics over time. So that's a very important common theme, I think, which is demonstrated by our three panelists, but also is demonstrated by the actual, what's happened over the decades and the success that, and what you can actually rely on. I will mention one thing that we are thinking about here at Weill Cornell, New York, in terms of what's COVID made us think about changing, and that is, and I mentioned it a little bit earlier, but just to flesh it out a little bit more, we're very keen on the idea of international, collaborations, international consultations, if you will, international second opinions. That has a little bit of a different connotation, but the concept of it's more difficult to travel. It's going to be more difficult to travel. There's always going to be issues related to quarantine, et cetera. Plus, quite frankly, a lot of institutions are in a different financial state now, and they can't afford to have people spending as much time away or traveling and so on. So I think that it's going to be much more important for us to develop virtual connections, to be able to do virtual connections with people around the world. Now, you need to have some kind of a relationship to begin with, but yes, actually being able to connect virtually, whether it's for a lecture as opposed to flying there and being a visiting professor, or it's a consultation with a clinician about a complicated case, or it's about having their public health experts advise our public health experts about what they've learned in their country. Having these virtual connections, I think, is something we need to really, really embrace. There are definitely some regulatory, compliance, licensing issues related to practicing medicine in different countries and et cetera. And so we have to take those into account. But our international office is a very strong believer that in the next few years, this is going to become an increasingly important way that we communicate, not to replace in person and not to replace travel, but to augment it and be able to do things that otherwise we would have, frankly, considered only a prelude to a travel. Now I think it may be the primary thing. So we're working with our legal office here, and we'll soon be announcing sort of an Office of International Second Opinions. The idea being, we want to facilitate these communications going forward. And I think that COVID has taught us that it's important that we have these connections, and that, in fact, we can accomplish more than we thought we could accomplish by doing some things online and virtually, and hence this symposium today. So, we have we're over our time, but we're also not getting many questions from the audience. So we're going to keep talking to the panel here and getting questions answered from them. To what degree have you been limited by infrastructure, by Wi-Fi, by networks, by regulations of any type, or have you actually been able, has that not been such an issue as you've dealt in different parts of the world? We'll start this time with Dan.
Initially, I would say yes. We were well, when, many of our programs started. It was using the little blue pieces of paper that you wrote the letters on, and they got there a week later. But I'm amazed at just within the last 3 or 4 years the rapidity with which internet is booming in all countries, and the increase in bandwidth, so that that just seems to be progressing forward in all countries. And I agree with you that COVID has been horrible. However, if there's a silver lining, there is more flexibility. Jennifer and I were just meeting with the leadership of Weill last week in Tanzania, and they were excited about having faculty where they have some gaps in some of their education, having faculty from Weill, Cornell, or other international universities maybe perhaps filling a few holes by giving virtual lectures. I also want to, and this is more in Wolfgang's court, but I think the importance of what he's doing by providing continuing medical education is just so important. For example, in Tanzania, an MD that they're getting right out of secondary school, so they're sort of like a senior in high school when they're beginning their medical education. It's 5 years, so they're very young, and then they get the MD. Many will not go on to get a residency program, so they're mid-20s when they get that piece of paper with an MD. It's so important to continue to provide education and continuing medical education, and developing systems to provide all healthcare practitioners around the world continuing medical education is just so important. And Wolfgang's really been a leader in that. And then maybe sort of moving that out into, at the national countries where they would be able to adopt similar type programs. And that, again, that may be where the virtual education may be for a busy practitioner, may be difficult to travel to a conference, but if they could get CME online, that might be really helpful.
Yeah. And this is, I didn't give you a plug on this, but actually we're going to show a video later on. This is actually something we're very interested in here. This particular seminar is being hosted by Cornell. Cornell University in Ithaca has a rich electronic education platform. We are partnering with them to develop a whole platform of international medical education, which can be accomplished, remotely. And this is something we're planning to really promote in the upcoming months. The Cornell program actually already has many lectures on leadership, on healthcare systems, on population health, on many other issues that are actually applicable across specialties. We're planning to actually, specialty by specialty, create some content for exactly that internet, that online continuing education that for people who otherwise don't have access to it, who would have to travel or whose healthcare systems simply don't provide it. When we've traveled around the world looking at collaborations, for example, looking at potentially collaborating with local partners for clinics, for hospitals, et cetera. One thing we've heard every time from health ministries in countries like China is when we've met with them, they've said, "Oh, we would love for someplace like Cornell to come help us provide healthcare in this clinic. But what we would really love is for you to provide ongoing education for our doctors." That's what, oh, we would love that. Can you also provide that? And it's actually, in many ways, some of these connections are almost an entree to meeting that need, which in the Western world is something that we kind of take for granted. You kind of go to Grand Rounds every week and you get your continuing education. But in fact, that is something that probably is very much, glad you brought that up, Dan. Wolfgang obviously has been very far out in front of this, and it's a model program, but there's even more that could be done, we think, in the area of continuing education as a standard to reach around the world. So stay tuned on that, and we have definite ideas that that'll be an important area.
I'd like to just add one thing. I completely agree, Wolfgang. I know so many colleagues at Weill Bugando who have found your courses empowering and transformative. It's great. Who have come back and then taught what they learned to our colleagues, the rest of the colleagues in the department. So what you're doing is having real impact on doctors' education. And the other thing I just wanted to highlight, when this training is available virtually, it also expands the pool of who's able to access it. I would say I have many colleagues who, especially women colleagues, who would be very hard for them to leave their family and go somewhere for training. And now when something's accessible online, that's something that they can now participate in and gain from. So I think that also will contribute to building more equity in training. So I just wanted to say thank you, Wolfgang, for all your years of work leadership.
Well, thank you, Jennifer, but it is teamwork, and it is this spirit that you can also breathe in here at Weill Cornell, because everybody talks about Harvard International, but it's a business. About these Weill Cornell activities, not that many people know about it, but those who get involved, they can live on that, they can build on that. And that is, in my view, one of those remarkable differences by the spirit you find in this institution. But also responding to Dr. Stewart's comment about electronic and digital medicine. I mean, what we have done with one of our other partners, which, by the way, value Weill Cornell a lot, I'm talking about the Children's Hospital of Philadelphia. We designed a 3-year curriculum with the Children's Hospital of Philadelphia, covering basically all areas of pediatrics. And when the faculty from CHOP comes to Salzburg 6 to 7 times a year in the different subspecialties, we record their lectures, and we put them up on the internet. We created basically an electronic handbook online. It's called CHOP Open. CHOP developed this further with specialty lectures covering now literally all pediatrics. But the beauty of that program is, after 3 years, we take the content down, we take it off the internet, and put up the new content. So in other words, this free source provides free access to all physicians around the world in an updated version. So, and within 3 years, a lot can happen, but not too much. So in other words, you always get information not older than 3 years. And this is something that we could do, of course, with the other OMI seminars, which we actually do already. It's an issue of, there are some financial and legal issues involved in terms of copyright, but I think we have almost reached a level, and I think this is one aspect. The other aspect, I still believe that at some point you also have to connect person to person, and we should not underestimate that a travel from Tanzania to Salzburg and then they always combine it with a little extra time. This is very rewarding. We also have to respect these people because we want them to go back. They are dreaming to work in New York or in Boston. Those are their dreams. But we want them to build or improve the healthcare system back home. So we have to allow them also to participate in our world and respect them as a colleague at the same level. And therefore, I think we need the combination. And this is what Weill Cornell has been doing now for so many years. We should not underestimate also Weill Cornell Qatar. I mean, it's a wonderful institution, but maybe we can do a little more out of it and by collaborating a little closer, because I think we have really already achieved a lot. So this is, I think it needs a combination. Digital, postgraduate education is fine, but the personal contact is also important. At some point, you have to be able to shake hands with somebody, look into his eyes, and also show him, yes, you are a colleague of mine, you are a friend of mine, and I really will try to help you, but please, you do your job back home.
Yeah, I think that's a great, that's well said. And, you know, I think that it seems to me that COVID has definitely taught us that we can accomplish some things in you know, virtual online ways, and it's important that we do, and that these global networks, et cetera, are so important. But I also think it has taught us that we miss the interpersonal interaction. We miss the being in the same room, the eye contact, the connections that you can make in that way. And certainly we want to be able to get back to that. I've heard some people say things like, some senior people say, oh, maybe this is the end of medical meetings. You know, we should just all get together this way. And I think it's basically because those people are just tired of traveling. Because I actually think for younger colleagues, medical meetings are very, very important. It's very important to go to a meeting and actually be in the same room with your colleagues, and also with leaders that you admire or people whose work, people that you want to collaborate with. There's no replacing that. Now, you can amplify on it. You can add to it, but to some degree, I think COVID has made us realize that personal connection, colleague to colleague, is something that we really need and is going to be very important for us to try to reestablish at some level going forward, even if perhaps it's a little less and perhaps we do a few things virtually that we used to do in person. In person is not going away, I don't think. And I think that we're learning that in many ways. And thank goodness we had these interpersonal connections that we had built over many years to get us through this difficult time when we couldn't connect. And so it's all the more reason to reestablish those relationships because it's going to be very, very important going forward, certainly I believe. So I want to thank our three panelists here, Wolfgang, Dan, and Jennifer. We certainly admire what you have done. You've been, I hope the audience has enjoyed this. I can tell you all three of these individuals are selfless and tireless in their international efforts, and I was proud to be part of the panel with them. I think we're going to take a quick little break here, and then we will reconvene with our next panel in just a moment. So thanks again for everyone who's attending the meeting, and thanks to Dr. Zalitsky, Fitzgerald, and Downs for your contributions. All right, hello everyone and welcome back. So we have our final panel of our global virtual symposium today, and on this panel we have some new guests joining us. So I'm very pleased to introduce this panel, each of whom will make some individual remarks, and then we'll have a group discussion at the end. So I'll start with Dr. Lisa Newman. Dr. Lisa Newman is here at Weill Cornell. She's the chief of the section of breast surgery. She's also the director of the Interdisciplinary Breast Disease Program, and she has a tremendous amount of international experience, which she'll be sharing with us in a minute. So Dr. Newman, thank you for being here. We have with us Dr. Javed Sheikh. Dr. Sheikh is a professor and the dean of our medical college, Weill Cornell Medical College in Qatar. He's been there for many years, starting off as vice dean for research and then becoming the dean. So he knows the Qatar program very well. Javed, thank you for being here, and we look forward to your comments.
Pleasure.
Thank you. We also have back with us Dr. Alitsky, who you met in the last panel. And I invited Wolfgang to participate in this panel as well because I wanted his thoughts on the future of international healthcare. And so, Wolfgang, thanks for being on this panel. And then we have Dr. Mohammed Suleiman. Dr. Suleiman is the consultant pediatric cardiologist and co-director of the Kids Heart Medical Center in Abu Dhabi. Dr. Suleiman trained at many prestigious institutions in the U.S., including Columbia and Harvard, before taking his position in Abu Dhabi. He's held several leadership positions there. So, Mohammed, thank you for being here. We look forward to hearing from you. And finally, we have Dr. Rob Lorenz. Dr. Lorenz is an otolaryngologist, head and neck surgeon, so you know he's a good guy. And he is currently the executive medical director of market and network services for the Cleveland Clinic, but he spent many years as the chief medical officer of the Cleveland Clinic Abu Dhabi. And so Rob and I have shared international stories over the years, and it's a pleasure to have someone here from the Cleveland Clinic, which actually has, as everyone knows, a very robust international program. So Rob will share his thoughts personally and also give us some perspective from the Cleveland Clinic. So this panel is entitled International Collaborations of the Future. And I've asked each of our panelists to give just a brief introduction to their own international work. And we'll start with Dr. Lisa Newman. So Lisa, the floor is yours.
Thank you so much, Mickey. It's such a pleasure and an honor to be able to join you guys today. And as you mentioned, I will be talking about our International Center for the Study of Breast Cancer Subtypes, which is now, I am so proud to say, officially headquartered as a center at Weill Cornell Medical System. And the genesis of this particular international collaboration is really rooted in my desire to better understand the multifactorial etiology of breast cancer disparities related to women of different racial ethnic backgrounds. And I'll just summarize some of those differences. Breast cancer has a higher mortality rate in African American women, which is heavily related to the more advanced stage distribution of breast cancer in African American women. So those features are obviously closely linked to social determinants of health, poverty rates being higher in the African American community, and barriers to accessing the healthcare system. So we clearly need to address socioeconomic disadvantages. However, there are several other features that characterize the breast cancer burden of Black women that cannot be ascribed to socioeconomics, such as the younger age distribution, the higher frequency of triple negative breast cancers, which is a biologically aggressive form of the disease. And male breast cancer is actually higher in the African American compared to white American community. So we really do need to study the possibility that African germline genetics may be linked to some factors associated with hereditary susceptibility for certain forms of breast cancer. So this is what led us to want to understand better the breast cancer burden of women that reside on the continent of Africa. Now, Africa is a huge continent, obviously, and it's also the founder population for all of humankind. So it's characterized by a tremendous amount of genetic diversity. So studying the breast cancer burden of women in Africa means that you really do have to study different regions of Africa. So we chose to start in our international collaborations with studying the breast cancer patterns of women on Western Sub-Saharan African regions, represented by women in Kumasi, Ghana, compared to women in East Africa, represented by women in Addis Ababa, Ethiopia. And this is still a simplification of the genetic diversity of Africa, but this is how we started. We had to start someplace. And we learned quite a bit from this simplified way of studying the breast cancer burden of women in different parts of Africa compared to African American and white American women. The biologically aggressive form of breast cancer that I mentioned to you previously, triple-negative breast cancer, is very, very highly prevalent among women in Ghana, in Western Sub-Saharan Africa, but it's actually pretty uncommon in women on East Africa, represented by Ethiopia. The frequency of triple-negative breast cancer for African American women is actually intermediate between what you see for the women in Ghana and what you see in white American women and European women. So we feel that this actually supports our hypothesis that there is something associated with hereditary germline genetics of African ancestry and triple-negative breast cancer risk, but it specifically seems to be associated with Western Sub-Saharan African ancestry. And this is the area of research for which we've coined the nomenclature oncologic anthropology. And it makes sense if you simply look at the patterns of the African diaspora over the past several centuries. The transatlantic slave trade from the colonial era of our country brought the ancestors of Ghanaians, Western Sub-Saharan Africans, across the ocean to serve as slaves in the colonies. And so as contemporary African Americans, we have quite a bit of shared ancestry with contemporary Ghanaians. The slave trade from East Africa, on the other hand, was largely brought further eastward to the Mideast and to Asia. And so as African Americans, we have less shared ancestry with contemporary East Africans, including contemporary Ethiopians. So we are now investigating the germline genetics specific to Western Sub-Saharan African ancestry as it pertains to risk of having a triple-negative breast cancer. And what we've learned actually is some fascinating work with regard to the genetics of different variants that have been generated over the past several millennia. And we've actually identified a particular germline genetic variant associated with Western Sub-Saharan African ancestry called the Duffy null variant, which is a variant very tightly linked to Western Sub-Saharan African ancestry because it's a genetic variant that confers some level of resistance against malaria, which is obviously a hugely deadly disease and has a very strong history of being endemic in Western Sub-Saharan Africa because the many watery, low-altitude areas of that part of the continent support the mosquito life cycle, which is the host for the malaria parasite. So the Duffy null variant, because of the resistance that it confers to some forms of malaria, is nearly fixed. You see it in almost 100% of Western Sub-Saharan Africans. That Duffy null variant came across the ocean with the transatlantic slave trade, and we see it in about 75% of African Americans. Not 100%, because of course we have quite a bit of genetic admixture with European ancestry. And if you map out the frequency of this Duffy null variant against frequencies of triple-negative breast cancer in different parts of Africa, it very closely links the Duffy null variant to the frequency of triple-negative breast cancer. And our ongoing work is looking at connecting the dots between the Duffy null variant, the immune landscape of mammary tissue, and risk of getting a triple-negative breast cancer. And again, we've been learning some fascinating things that are teaching us not only about some of the factors explaining breast cancer disparities here in the United States, but these genetic research efforts are teaching us about the root causes of a biologically aggressive form of the disease, triple-negative breast cancer. And so we are very excited about ongoing efforts in this research. And the project, again, as an international study, is rooted in our desire to learn more about disparities from a research perspective, but it's evolved into so much more than that. These international partnerships are also very exciting ways of developing wonderful friendships across the ocean. And it's been a very fruitful way of actually investing into the healthcare systems of the low and middle income countries of the continent of Africa. We've been able to promote multiple academic and training exchange programs between our students, residents, researchers. We've been able to invest in the pathology services of the programs where we work in Africa so that they can characterize their breast cancer patients better. We've been able to develop in the clinical services, the surgical services of our partners. And we've been able to invest in the research infrastructure of the hospitals that we partner with. So very, very exciting for many reasons. We've been happy to see robust expansion of our program so that we now not only partner with Ghana and Ethiopia, but we have other partners in different regions of Africa, Uganda, Nigeria. We are now partnering with the countries in other parts of the world. Mexico, thanks to our robust work here at the Weill Cornell Medical School. And we are looking at the breast cancer burden of women in the Caribbean as well. So very exciting. We look forward to more expansion. But as I'm sure all of my other colleagues on this session will share with you, this work is indeed very costly, and you have to be personally invested in it 250%, not only in making sure that it survives financially, but in making sure that it continues to thrive in terms of generating more people involved with the work so that it endures over the future. And so again, thank you for letting me share this time and participate in this session to talk about our work in breast cancer.
Great. Thank you very much, Dr. Newman. We'll turn it over now to Dr. Sheikh to tell us a bit about Weill Cornell in Qatar. He gave me one of his intro slides, so I gave you some of the intro, but also in particular, Java, talk about your education network and how you're developing an international network in terms of educating health professionals. So, Java.
Thank you. Thank you, Dr. Stewart. Thank you all. It's a pleasure to be here. I really appreciate the invitation and the opportunity to share what we are doing here. So we started our operations in 2002, and the mission was the same as our mother campus in New York, which is to produce truly first-rate physicians and physician scientists and to use discoveries to really transform health. In terms of what we have done in the last decade and a half, we have produced 463 physicians now. Our upper ceiling is 50. We started with about 15 graduates the first year, 2008. And of those 463 graduates, most of them have gone to the US for residency training, and 25% have come back and they're serving the country. So we are populating the country with our own trained physicians. The second thing which we have done is, in terms of upgrading the clinical care in the country, about 750, I think it's more than that now, physicians have clinical faculty appointment. And these are the ones we have selected over the last 15 years very carefully. And they fulfill the same criteria as Mother Campus clinical faculty in New York. So they have clearly upgraded the overall care. In collaboration with our returning alumni, these people are now in positions of healthcare leadership in the country. In terms of our research mission, we have produced numerous publications in the last 10 years since it was established, the research mission. Our Z-index is above 90 now, which is truly in the same territory as our mother campus and other elite institutions in the US. And I'm very proud of that. Getting back to what we are doing for the community, which is where I'm going to come to, Dr. Stewart, that's what you were asking. A few years ago, we decided, about 6 years ago, that we need to, now that we have fulfilled, or at least we are on the way to fulfilling our original mission of producing healthcare leaders and physician scientists and producing publications, we need to really focus on making a strong impact on the local community here and the international community. And I'll just give a couple of examples. Local community here, we have rolled out very comprehensive population health programs, starting with the elementary schools here, going into high schools, restructuring cafeterias, providing health education to the students, and setting up greenhouses now in 134 public schools. And we are rolling out very specific projects now, pilot studies initially, and later on larger scale studies using apps in terms of exactly what the students are eating, looking at their overall lifestyle from sleep to what they eat, the physical activity, and then ultimately the impact on their academic performance. This is something which has been very well received. Because of the pandemic, we were also asked to get involved by a statistics center in terms of looking at the numbers of the patients and how best to mitigate it. I'm very actually humbled to say that our group has published multiple publications in New England Journal of Medicine. And in fact, CDC made one of its booster recommendations based on the data both from Qatar and Israel. And so that was received very well and was in New York Times and then picked up by CNN. Getting back to more of a global impact, in collaboration with the National Academy of Medicine, with Victor Zhao, we established this Innovations in Global Health Professions Education. We are very mindful that we are fortunate here that we have very generous sponsorship from Qatar Foundation on the one hand, and we, of course, have all the support of our mother campus in New York. And we felt that we need to create an organization which gives the opportunity to others who might be less fortunate in terms of resources. So we can set up conferences, symposia, podcasts, and disseminate other information in real time, open access journal. So that's what we have done over the last 6 years. We have held multiple conferences, mostly in Asia, and we'll be moving on to Africa, hopefully very soon. And that's where most of our collaboration going forward will come. One thing which I do want to mention here is that about 8 years ago, we started our continuing professional development program here also, which was to help the clinicians, all kinds of health professionals here in the country and in the region, MENA region, which is Middle East and North Africa region, to upgrade their knowledge and clinical skills. So we are doing that also. But going forward, a lot of focus would be on innovations in global health professional education. I heard Wolfgang, our colleague, of course, from Vienna and from Weill Cornell in New York, talking about the need for better collaboration between his program and ours, and that's music to my ears. We are looking forward to having a detailed discussion as to how we can do that. Because in addition to what we do here, we are very much believers in technology. So we have created this AI center on health and education recently. And there is a team of data scientists, along with postdocs and some of the other existing faculty members who are quite versatile and facile in data science. The focus really is on using refined data analytic techniques to look at publicly available databases in the country and then internationally, and also looking at the data available from mobile apps and wearable sensors to really make it easier to do early diagnosis and make our contribution toward personalized health, which is where everyone has to move to ultimately, and in the long run to really enhance the lifespan. So in summary, there are multiple areas in which we are making our contributions. But if I had to focus on one thing, I would say that is to upgrade the clinical care in the country of Qatar, which has been very generous to us, and to make contributions globally so we can bring that collaboration to other parts of the globe also. So I'll stop there. Thank you.
Thank you very much.
Thank you for the opportunity. Yeah.
We look forward to some more discussion on the panel. So
Definitely.
Next, I'm going to ask Dr. Suleiman to talk about the Kids Heart Center and your own international work. So please.
You hear me now?
Yes.
Okay. Thank you very much for inviting me. And I feel, Kids Heart is a very small thing in these big institutions that include, New York Presbyterian, Columbia, Cornell, and all of this big institution. But I will give you a small summary about what we tried to do. We started about in 2013. I'm going to share my screen with you guys. So we started in 2013 as a Kids Heart with two main cardiologists. And the main idea behind the start of Kids Heart was we realized in a country like UAE, even though it's a rich country, but there is a lot of disparity between different population in the country. So we realized that people who, especially in pediatric subspecialties, that there is a lot of gap of access in addition to very well qualified people who can do very good work. Me and my partner, Dr. Hamdan, we started as a pediatric subspecialty in pediatric cardiology, and very soon we got affiliation with our partners in New York Presbyterian Hospital, who really make this adventure a big deal and has a major effect in the ground going up in UAE in pediatric subspecialties. And this is when we got appointed, me and my partner, and we have Dr. Basha and my others who's there, got appointed as a part of Columbia University associate. And from there, we start doing some work together. And the small program that we started at pediatric subspecialties expand to almost every single hospital in UAE, including government and private hospital, providing pediatric subspecialties, and included ourselves in even education inside schools and other program. So the other thing that we direct ourselves is education. So with education, we have done almost about 10 face-to-face international pediatric conferences where we have our partners from New York Presbyterian. They will come over here 6 to 8 at a time. We do it twice a year and get very well attended with about 600 to 800 people from UAE mainly. And during COVID, we had to change it to instead of virtual, but we just got our last seminar a few weeks back in October, and it was very well attended. We made it sure that we're going to do it face-to-face instead of doing virtual, and it was very successful with a lot of attendees, about 300 to 400 during COVID time. So the thing that we say that help in building relationship in pediatric subspecialty with our affiliation with the New York Presbyterian, that they help us to build a lot of subspecialty education. We start sending even medical students. We are able to attend their own CATH conference, get direct hand-on consultation with some patient who need to ask about specific question, regardless of their ability to travel or not to travel. Of course, this kind of program has gained a lot of momentum, and we become really a very well-known in UAE as the main provider for pediatric subspecialties, both in education and in care. And I'm just here sharing with you some of this, pictures of the program that we are very proud of the education. I avoid to bring any patient picture, but I think the point is that for any program, in my opinion, to be successful, regardless if it's small or big, it will depend on bilateral relationship and not only one side, where you give back to the community, you give back to the people who are desperate for getting more education, more knowledge, more care in the ground here in UAE or any other Middle East country. I just want to say thank you to our partners at New York Presbyterian, and we are very proud to provide the best care in pediatric subspecialty in UAE. And that's all what I want to say. Thank you very much.
Okay, thank you, Dr. Suleiman. If you can stop your share there.
Okay.
So we will turn now over to Dr. Rob Lorenz. And Rob, if you could tell us about the Cleveland Clinic Abu Dhabi, and also just your own international experience, and also kind of Cleveland Clinic's global international strategy. So, Rob.
Can you hear me okay, Mickey?
Yes.
Good morning, everybody. Thanks for the opportunity. So I've been here with the Cleveland Clinic for 26 years now. Spent 3 years in Abu Dhabi, as Mickey said, as the Chief Medical Officer of the Cleveland Clinic Abu Dhabi. And I wanted to bring it back into historical contents for just a moment. Our organization is celebrating its 100th year anniversary. 2021 was our 100th year anniversary. And we're not located in New York. I'm a native New Yorker, but we're not located in New York. We're located in Cleveland, Ohio, which is a little bit harder to get to. And when you look at our initial innovations in medicine, there are many, but I'll just focus on the cardiac, for example. 1958, Mason-Sones did the first angiography in a living person. And then in 1969, Dr. Rene Fabrero did the first coronary bypass using a saphenous vein graft. So at one point, there was only one place in the world you could go and get your coronary artery fixed if you had an occlusion, and that was in Cleveland, Ohio. And a tremendous volume of patients came here for cardiac procedures from around the world. And that quickly turned into folks getting trained here to do cardiac procedures. And indeed, my wife is Turkish, and the reason is because her father, a cardiologist or cardiac surgeon from Turkey, was here in the U.S. training and knew of the Cleveland Clinic program, and that's why he was trained here. He went back to Turkey to practice for many, many years, but we quickly educated professors from around the world to do those technical procedures that we could do here in the U.S. Now, fast forward to today, where the differential just is not there, from going from one place in the world to many, many places that do outstanding quality. There is a tremendous leveling of the procedural capabilities throughout the world. So seeing this, our CEO, Toby Cosgrove, said, listen, we need to get out of Ohio and go to the patients where they may be. So I have a couple slides if your AV folks want to show that. We do have a large footprint in Florida, in addition to Ohio. Out in Nevada, we have specifics around brain health. And up in Toronto, we have an office that's a lot of procedures, a lot of diagnostics, but no inpatient in Canada. But the real mainstay of our international work is in Abu Dhabi. And so Cleveland Clinic Abu Dhabi opened its doors to first patients in 2015. And Mickey, I can't see the slides. I don't know if somebody else can. And you're on mute.
They're up for the attendance.
Fabulous.
Yes.
Okay. So Cleveland Clinic Abu Dhabi is a 364 bed facility, expandable up to 490, and centers around some of our historic strengths, which include neurologic disease, heart and vascular, digestive disease, respiratory, and ophthalmology. It has 360 physicians and caregivers from over 80 different countries. And that was really the first footprint that we took internationally. The second one is in London, and our Cleveland Clinic London will be opening in January, and that will also be centered around procedural care, again, working with our strengths around cardiac, digestive disease, neurologic, and orthopedics. And then finally in China. And if you go to the second slide, you'll see the different types of affiliations that we have. And so the point is that not one all size fits everybody, that you do need to kind of answer to the needs of the market. So you see everything from an unbranded consultatory agreement all the way to what we call a greenfield, which is London. So in Abu Dhabi, we have no ownership in Cleveland Clinic Abu Dhabi. One thing they did not need was our capital. They did ask for our model of care. And what is our model of care? And that's very important. It is a not-for-profit, so all the proceeds go back in the organization. It is completely physician salaried. So I've been here for 26 years. never once heard about my productivity, never once talked about we need to do more of these procedures or more of these tests. It is 100% salaried. That gives you incredible flexibility. I heard on the panel more earlier this morning about kind of dividing up and sharing where the revenue comes when somebody comes. It all is very simple in this type of model. It all goes one place. And if you're completely salaried, all of those funds then flow either to the technology and the infrastructure or to the professionals, and it keeps things very, very simple. And the third part is the tripartite mission. So we first started with clinical care, but rapidly realized that if you don't have education and research, and I appreciate all the things that we've been talking about, education and research, you really can't have a sustainable program. First of all, the innovation is not there if you don't do research, especially on the local basis, because locally people have different problems than they do all over the world. And secondly, on the education part, you don't have a sustainable workforce. And I salute what's been done in Qatar with Weill Cornell there. You've done an outstanding job educating folks who then come back to the community and can relate to that community that much stronger. And indeed, similarly, our research and education have followed on the clinical part in Abu Dhabi. In London, it's going to be a different type of play, and that is it's going to be a wholly owned entity by the Cleveland Clinic. And why is that? Well, they have outstanding expertise in London, but sometimes that model, that salaried model with very high technology and some infusion of capital is very helpful in a system such as the NHS system. So that is a private hospital in downtown London, right behind Buckingham Palace, that will utilize all of the fantastic professional IP and resources that the UK offers, but really have a place to store them in that outstanding technology. And so we're bringing some of the highest technology to the UK market. So I'll be happy to lend you more of an insight into having those different types of organizations around the world, different types of model, and how the Cleveland Clinic breaks out of a place like Cleveland, Ohio, to make sure that we leverage our strengths around the world when we deliver care.
Thanks very much, Rob. And as I mentioned earlier, Cleveland Clinic has clearly been an international leader in its international collaboration. So it's great to have you on this panel. So finally, I'm going to ask Wolfgang to talk a little bit about healthcare of the future, and he was going to give a couple of examples of how the Salzburg seminars potentially can lead to that to some transformational change for the future. So Wolfgang.
Well, thank you very much. Again, I think if we want to have an impact on the healthcare delivered in other parts of the world, we really have to think about changing or improving the situation locally. And this, of course, has a lot to do with the existing political situation, but also with cultural aspects. But most importantly, you have to have relations. You have to know the people, and you have to identify people that you want to work with, but they also need to wanting to work with you. And therefore, the OpenAI Institute, I see this as a basic infrastructure which I would like to make available to everybody who is friendly with Weill Cornell. And as Mickey already mentioned beforehand, the OpenAI Institute was started by Weill Cornell physicians. All the other institutions who are now participating in this program were only invited after negotiating and getting the okay by Weill Cornell. That is true. I just want to give you an idea how that happened, because otherwise you may misunderstand, for example, our relationship with the Children's Hospital Philadelphia. When we started this program in the early 90s, the pediatric department at Cornell was not that big. So they could not have covered all areas of pediatrics. So we had to find a partner, and that was the Children's Hospital Philadelphia. There was also a time, not now, but there was a time when Weill Cornell of New York Hospital was a standalone institution, and their cardiac thoracic surgical program was also not that big. That's when we started our partnership with the Cleveland Clinic. And due to the merger, the Columbia University came into the picture. we have never changed any of these partnerships, and I think this is one of the strengths. But the most important partner by far is Weill Cornell, and there is a very special spirit in this institution to be open to the world, but they're not talking about it. Now, when it comes to the different countries, I mentioned already Mongolia today, we have trained now 7% of all Mongolian doctors. But we have also trained, for example, 2.5% of all Czech doctors. And the Czech Republic has some very fine institutions like the Charles University in Prague. And today, the Vice Dean, many chairmen, they're all former fellows of the Open Medical Institute. And this is the basis for partnerships. And of course, partnerships on an academic level, they are in the clinical area, but also in research areas. And this is where I see a great opportunity for the future involving telemedicine and digital medicine, in particular when it comes to early diagnosis or a program for second opinion. And this is an area where we can collaborate. And this also pays off for the different countries we are dealing with. Because once you have established a partnership with an individual, soon you will also be able to establish a partnership with an institution. But you have to maintain that institution. And there are several tools. The tools are, for example, only offer short-term programs. One of the biggest problems for closing down the collaboration is, for example, a long-term fellowship. You invite the person you're dealing with to come to your institution, spending 1 year, 2 years, 3 years at Weill Cornell or at Rockefeller. It's very difficult for these people to go back. But you can achieve almost exactly the same when you invite that individual 3, 4, 5 times for shorter periods. Because this not only fosters the existing relationship, he always takes something home, and he will try to implement what he has learned back home. And if he's unable to do it, we will not be able to do it. He has to do it. And we have to give him the power. We have to empower these people that they go to their politicians, that they go to their leaders and tell them, this is what we need. And this is important for our healthcare system. But also, for example, exchange programs or awards or professorships. What, for example, Weill Cornell has also shown in collaboration with Weill Tanzania, for example, also with Haiti. This links somebody who's working in Haiti or working in Tanzania with Weill Cornell. And this is, I think, a potpourri of different opportunities how to help the people that we got in touch with through, for example, OMI or through Weill Cornell Qatar, that we maintain that relationship and help them to be successful in their own country. So it's a time issue, but it's also an issue to be a reliable partner and maintain this relationship over many, many years.
Great. Thank you, Wolfgang. So I'd like to ask the panel for their thoughts, and I'll call on each of you as we go down here. But now that we've all of you come at this from a somewhat different perspective, you've got different angles on international healthcare collaborations. How do you see the next 5 to 10 years evolving as we come out of COVID, as we have better technology, as we have these existing relationships, which the importance of international communication and collaboration couldn't seem more important than it does today, given a global pandemic. So I'll start with you, Javid. What do you see is the future of international healthcare collaboration, and what should all of our institutions, including the institutions of those who are participating? There's actually over 200 people observing our seminar at this point. All the various people from around the world that are observing. What should we all be thinking about in terms of preparing for the future, in your opinion?
Thanks, Mickey. Yeah, so even though it is a cliche, I think finally the time of high tech and high touch has probably arrived. I mean, given the pandemic, there is no question that all the digitalization which was going to occur over the next decade or so has been accelerated. Yet at the same time, just looking at the rates of anxiety and depression all over the place, particularly amongst healthcare professionals, we also recognize that there needs to be a way of using technology which takes into account human touch and relationships that Wolfgang was talking about earlier. So there needs to be, I think, a hybrid model, which is to use technology as telemedicine, all of that, and yet at the same time, deepening relationships, whether they are with face-to-face meetings or whether they are ongoing Zoom meetings like we are doing here, but not to underestimate the value of human relationships. So it needs to be, I say, really, let's go full out. I mean, I am a big fan, by the way, of AI and the applications. I have been for about 20 some years when it didn't used to be called AI, but like, expert systems and this and that. But finally, I think the time is arriving, but it's not to displace the human touch or the physicians or healthcare professionals, but to complement and make it to enhance our skill set. And I think that's a model which needs to be implemented. Very comparable examples are, I mean, you have decentralized finance and fintech and all of that. The human relationships are important over there. Here in medicine, in healthcare, even more so, getting people involved in their own healthcare, using the wearables and the sensors. Well, I can go on and on, but I would say the core and the crux would be really, again, using the cliche, the high tech needs to be complemented with high touch. That would be my mantra.
Thank you very much, Javed. Dr. Newman, what are your thoughts about the next 5 to 10 years and what wise people and institutions should be doing to be prepared?
I'm excited about continued growth of these international collaborations in the next 5 to 10 years. As horrible as the COVID pandemic was, and still is pretty horrible, it has made us all pivot in the way that we work with each other and in allowing us to become more comfortable with these virtual interactions and the Zoom technology. Our breast cancer research program is 16 years old, and it was very, very heavily vested in travel. Our group would go to Africa 2 to 4 times a year for clinical service operating, and we bring our partners here to the United States for exchange training programs a few times a year as well. And obviously that all had to stop completely with COVID, but we did pivot like everybody else, and we've actually interacted even more through the virtual technology, and we continue to have our annual conferences, we continue to interact with our training programs, but we've just done it virtually. We are, however, looking forward to the personal interactions, and hopefully we'll be traveling again in 2022.
Great. Thank you, Lisa. Rob, Lorenz, what are your thoughts about the next 5 to 10 years?
Thank you. I think that we'll be seeing more of a splitting out of that care that can be delivered virtually. So I'm thinking about virtual second opinions, thinking about radiology, pathology, of course, and that's going to need that in-person care. We, in the U.S., Cleveland Clinic has the highest case mix index in the country, and that implies a tremendous amount of infrastructure in order to support that kind of complexity of care. And so that's why when we went to Abu Dhabi, we really initiated the transplant program over there. So now it's a full-fledged liver, kidney, heart, lung transplant program. Now just 10 years into it. Talk about an acceleration of capability. That was truly it. But there's a maturity to understanding the healthcare system that says, as you mentioned before, you're very adverse to going overseas because you're an outstanding surgeon. But you and I know that our expertise is predicated on about 100 people, whether it be the person who orders our supplies, the person who actually credentials us, credentials the people who actually credential us, right? It's a tremendous pyramid that we sit on top of. In order to replicate that internationally in developing markets, it's very, very challenging, right? So if you're going to start to do that type of tertiary and quaternary care, you need to kind of jump in with 2 feet. And therefore, your partner needs to appreciate that. There's going to be a whole other side of the conversation where, whether it be consultants or other entities come in and say, you know, you don't have to have somebody who is, credentialed in cleaning rooms. Well, you and I know that you do need that. You do not know, you need to understand the provenance of the medications and where they came from. Well, you and I know that if they sit on the loading dock for 2 weeks in 150-degree temperature, that medication won't work, and you and I will not be effective as physicians and as surgeons. So it's a tremendous maturity of the entire healthcare system that delivering tertiary and quaternary systems internationally requires, and we're excited to be part of that wave. So I think what you're going to see is that procedural care in certain locations will continue to grow as those capabilities grow, but then those things that can be done virtually will obviously expand as well. So those 2 areas.
Thank you, Rob. That's very helpful. Dr. Suleiman, what are your thoughts about the next 5 to 10 years? I'll get back to you, John.
It's really amazing to, what I will say is our health system in general is a moving target, and either internationally or locally. What I will say is that strengthen a relationship with local partners and make it understand from them, from their side, what do they need, not rather than telling them this is what you should do only alone. So it's bilateral relationship that will build on the need of the population. And when you achieve one target down the road, then you move to the next. You start sometimes as an example with teaching people how to do cardiac surgery, but later on, you already have good people who know how to do it. But as a country or as a big university who has a lot of technology, maybe you'll need to teach them later on how to do robotic surgery as an example. So there is always something new you will need to share, you will need to teach, you will need to collaborate with others for it.
Thank you. Javed, you had
Can I follow up? Yeah, I actually want to follow up on Rob's comments. I mean, Rob, I'm very familiar with all the good work you guys have done in Abu Dhabi. And when I was listening to you regarding, pushing, basically using technology to enhance tertiary quaternary care in, other parts of the world also, what I'm thinking as an educator, we as educator have been somewhat slow to adopt the technology. We really have been in terms of training our medical students. It's very traditional. Do you have any ideas how to push the envelope over there? I mean, I serve on some panels, National Academy also. It's just, I shouldn't mention names, but it's very conservative. We all are, as educators, very conservative. We just tend to go very slow. I mean, the whole curriculum thing just is, it crawls, it doesn't move. You, as someone who has actually established institutions as a CMO in Abu Dhabi and other parts, Cleveland branches, how do you deal with the requirement of education? How do you educate to make sure that those clinicians who are providing the service are actually on the cutting edge and are current?
Javed, and I think Wolfgang is a great personification of this. It's not just more of the same. It's a total different perspective. So we actually have a center for virtual education in our medical school. And they say, listen, this is not about Zoom meetings. This is not about just delivering the same content. It's about getting real live feedback, not from one person by calling on them, but from everybody and asking those conversations like, do you understand this material? No, it wasn't well explained. Well, let me go back and let me change my actual lecture style to say, what can I do to make this more relevant? It's about bringing more technology where it's not just me speaking at you and going through a PowerPoint slide. It's me speaking at you and going to a patient story, me speaking to you and then going to the anatomy lab, me speaking. It's a different way of looking at education. Frankly, young people are not that engaged by just a talking head. They're not. They need that constant level of engagement to say, what do you think we should be doing? How do you approach this material? So I can't tell you, I can't emphasize for you more that concept of just not scaling out what we've been doing for 100 years, but coming from a completely different perspective. You're exactly right.
Thank you.
Thank you. Wolfgang.
Well, yeah, there's not that much to add. Maybe a couple of examples how you can implement this. For example, when we did our cardiac surgical seminar lately, one of the main topics was the implementation of a pacemaker. And it makes a completely different story whether you watch a surgeon putting in a pacemaker or you give them a heart, which is of course not a human heart, it's the heart of a pig, and show them exactly where they have to place that sonde, where they have to put it, and what damage they can do, and then finally do it and have it checked. It's like an examination by the surgeon observing and watching that procedure. They will never forget when they have to place a pacemaker how many things could happen and what needs to be involved. A similar situation is our temporal bone seminar. I'm sure you know about the new devices where people who are really deaf can gain some hearing or almost complete hearing. And there are a couple of companies who are providing these devices. Again, we invite our people, we give them a specimen of the temporal bone, we give them a microscope, and we teach them how to do it first on the cadaver. I know these are old-fashioned ways of teaching. These are all ways of teaching, but on the other hand, I think this is still important. When they need an update, you can use virtual education, you can use other tools. So I am an advocate of combining those two techniques and technologies, and I think when I listen to Javed, we are on the same page. When I listen to Rob, we're also on the same page. So we know what to do, but it doesn't happen that often. And we are one of the programs that we raise a lot of funds just in order to make this available, to make this happen. And this is, I think, where such a group of outstanding institutions as the one that Mickey has gathered here today, we should focus a little bit more on implementing what we know. This is my comment to this situation.
You know, one thing I would like to comment on, and I think we've seen this happen kind of in practice over the years, but it seems it's probably worth at least putting out there, and that is that, you know, what a lot of places want from advanced healthcare systems, U.S., Western Europe, Canada, Australia, other places like that. It's not all about the U.S. There's other advanced healthcare systems, is they want us to come in and teach them the advances. But the reality is, Rob used the term, you're sitting on top of a pyramid. You can't go in and teach advanced care until you have nurses that can take care of the patient when they leave the suite and go back to the room, until you have the technologists that can run the equipment that will diagnose the problem, et cetera. And I think people try to make that jump a little too quickly. And it's really a mistake. I think that what you have to do, and you know, if you think about the Salzburg seminars, for example, I can remember people coming to the Salzburg seminar, young people, and saying, "Oh, I'm so disappointed. In some ways, I'm inspired, but I'm disappointed because when I go back to my country, my professor is not going to let me do these things. He or she's still the boss, and what I'm doing is intimidating to them." And, you know, I think there is some truth to that in some countries. But the reality is that person that you trained and you inspired is going to become the boss. And then they're going to remember that they learned this and they're going to be able to implement it. It's not going to happen right away. It's not going to happen the week after they get back from the seminar. But planting those seeds, teaching people, teaching the trainees, teaching the young future leaders what is possible, having them realize they can go to an international meeting and actually collaborate with their international colleagues. And actually have something to contribute. Then when they go back, it may not happen overnight, but as you put those building blocks in place, and they become leaders, they become in a position of influence, it will happen. And but you can't get to those level, you can't get to that tertiary level until you're dealing with everyone else at other levels along the way. So these are long-term projects. Different countries, different healthcare systems are in different states of evolution, and it's important to kind of realize where that is. But it's also important to start now, because in order to really be able to improve healthcare in 10 or 20 years, you're going to have to start now with the trainees and the people who are actually open to these ideas, because maybe the country's not ready, but what you need is people who are ready when the country is. Rob, you had your hand up?
Yeah, Mickey, I just want to give you a quick story, quick anecdote. So that, two things that countries often want from us is our healthcare, but also our defenses, our national defense. And we were one of the founders of the American Chamber of Commerce in Abu Dhabi. It was us and 6 other defense contractors, which meant make sure some interesting luncheons. But my brother's been with the Navy for years with our international partners, and he said, when you go to a sophisticated partner, they're not interested in the Top Gun pilot and all the tip of the pyramid. They're interested to know the certification process of the hydraulics engineer on the plane. They're interested to understand the provenance of the jet fuel, where it came to before it got into the jet, right? That's that level of sophistication of understanding the pyramid. Similarly, in healthcare, we have something that's so complex that those who understand that pyramid are going to be ultimately successful. So when we created our medical school here in Cleveland, it's not a physician med school. It is a medical school that's actually allied health, nursing, and physicians in the same building, actually being educated at the same time. Can you believe it or not? That's unique. So my point in all that is, if you're going to walk the walk and say that all of those different disciplines are as important to the ultimate outcome of the patient, you've got to create your structure, your organizational structure, to match that emphasis. And I think when people come here and they see that type of collaboration in education, then when they go back, they say, that's just as important, all those other different pieces of the puzzle.
Thank you, Rob. So Lisa, I'm curious about your thoughts about where is the next wave? Where should we be looking? We in the West, and where are the next areas potentially for international collaborations? The international collaborations have in some ways gone the way of resources, but not entirely. I'm actually proud of the fact that while Cornell, and this is not, I'm not making a value judgment here, I'm just looking at gross domestic product and national data. While Cornell has been a long affiliation with one of the wealthier countries in the world in Qatar, and also one of the poorer countries in the world in Haiti. And we've been in both places for 20 plus years. So it's not just about following the dollars, it's also about, and in Africa and other places. It's not just about revenue, it is about where the need is. But on the other hand, some places where there's need, there's major problems with infrastructure, with funding, with, quite frankly, corruption, and other issues that we have to take that into account. So what do you see in the next 10 years are the places around the world that are ripe for these sorts of collaborations and what we should be thinking about?
And thank you so much, Mickey. So, of course, I would like to try to emphasize the importance of improving the healthcare delivered to cancer patients in the low and middle income countries of Africa, because the needs there are just so absolutely huge at every level. And the cancer burden, non-communicable disease burdens in the low and middle income countries of Africa is rising precipitously as populations in those countries live longer. They are developing more of a cancer burden with the aging process as they adopt more of the westernized lifestyles and the commercially cheap food, fast food products are, popping up all over Africa. So that, those types of, non-nutritious food sources are contributing to the cancer burden as well. So for a whole lot of reasons, the cancer burden is rising in Africa, but we're not seeing a rise in the resources available for delivering appropriate cancer care. And here's where I think we also need to underscore the importance of partnering with industry. Industry really does need to step up in making sure that the very basics of supplies are available to our partner physicians and healthcare institutions in Africa. Even when the hospitals have the money to purchase supplies for pathology equipment, imaging equipment, surgical supplies, they run into tremendous roadblocks with the vendors getting those supplies to them in a timely fashion and getting supplies to them that are affordable. So I really think that the time is now for industry to step up and partner with us and to address these supply chain issues.
Thank you, Lisa. That's a very, very important comment. Thank you for making that. Javed, what are your thoughts? What are the areas in the world that are ripe for this sort of thing in the next 10 years?
I guess I will be a homer for a change here. I mean, I am right now in Asia and the Middle East. I mean, I think there is when you look at a whole lot of economic growth going on in Asia at this time, and you see that the certain aspects, certain sectors are lagging behind, and just look at healthcare. It seems to me there'll be a natural for healthcare sector to catch up. And those institutions, organizations which are in the forefront would have to take the lead. I mean, Cleveland, Rob's organization being one example, of course, Weill Cornell being the other example, and then there are others which have a very strong footprint internationally. But I think we will have to be, from the US, the organization will have to be quite aggressive. My own, because I am here in this region, my own feeling is that if we are not aggressive, there will be competitors, and we might not have that kind of luxury that, okay, well, because our technology is superior, because our education is superior, we can take our own maritime. I think we'll have to be quite aggressive in Asia in particular, because you'll have other players coming out from, let's say, India, from China, and other countries. Singapore.
Thank you, Javed. I have to agree. I think Southeast Asia is a huge, China and Southeast Asia is a huge opportunity. There's tremendous population, there's economic growth, there's need, and there's better connectivity with the Western world. So I think that's going to be a huge area. I think the needs in Africa are just staggering. A huge issue in Africa is there's so much variability in infrastructure, in support, in continuity, of leadership, et cetera, that it makes it a challenge. And it's very unfortunate because the needs are so large. And I so much admire people like Lisa and Jen Downs earlier and many others who are making great efforts in Africa because the needs are so large. But it seems like there's a lot of other things that really probably need to evolve or at least standardize across Africa in some ways, for us to really be able to get to the people, to get the health screenings and things like that. I mean, you're too busy putting out the fires to be able to actually go around to do the preventative measures that are really going to ultimately be needed for healthcare. And I hope we get there. I really do. But it seems to me that those are in South America, clearly there's established, developed healthcare in South America, but there's huge areas geographically in South America that are, and Central America that are quite in need as well. So I think there really are a lot of areas in the world, and it's a big world. There's I've said before, if you just look at the country of China, just think about this for a second. It's estimated that 250 to 300 million people will enter the Chinese middle class in the next decade.
Yeah.
That's what's the demographic changes happening economically. They'll enter the middle class, meaning they'll have economic choice. They'll be able to decide if they're going to buy a luxury item or not. They're going to be able to decide on where they get their health care, et cetera. A healthcare system like ours, Weill Cornell, Cleveland Clinic, systems of about that size, we probably see in a given year 1 million, 1.5 million unique patients. We may have more visits than that, but there's multiple visits associated with each patient. If you think about it, that means there's room for 200 healthcare systems the size of a U.S. academic medical center to be built in China to take care of the growing middle class in China that's going to be expecting a new level of healthcare than what they get from their government healthcare systems. There's plenty of room out there for all kinds of partnerships and collaborations. It's not like only Cleveland Clinic and Johns Hopkins and Weill Cornell are going to be able to benefit from this. I mean, there's all kinds of opportunity out there. The populations and the needs are just absolutely enormous. Think about the population of Africa, and think about if the population needs for healthcare there, and think about the size of the average, modern Western academic healthcare system. So there's definitely much more demand out there than would ever able to be filled, even by those institutions that have international aspirations. So, trying to make those connections, I think, just demographically is something we all ought to be thinking about. And there's plenty out there. It doesn't have to be a feeding frenzy in one or two countries or in one or two regions. I think looking for natural connections and starting to build this infrastructure is going to be very important. Now that leads to a question we got here because we were past our panel time and we're in Q&A. So we've got a few questions, and I'll ask the panel to address some of these. So we have one question from the audience, which is, what are the major barriers to creating international partners with other institutes of higher education? So I'll start, Javed. Why don't you take, what are some barriers to creating international partnerships with other higher education institutions?
Sure. Well, to begin with, I think it just seems that the countries, well, let's say potential partners outside the West, I don't think they are fully aware of how long it takes to really produce graduates of the kind that they aspire to have. And that's where the rubber meets the road. There seems to be a very big gap between the aspirations and the reality, which tends to be very slow. I mean, I have lived this and overcome the initial impediments, and it worked out quite well. But I think it's the first 5 to 10 years where there truly seems to be a very big gap between aspirations and reality. So how can one overcome? I think it'll be easy for me to say that it needs to be laid out. But even then, no matter how much you tell reality to human beings, our brain is evolved in such a way that I think it's very hard to be patient when the domestic pressure on them is to really produce and show some results, right? So my feeling is that in any kind of collaboration, there needs to be multiphasic plans, low-hanging fruits, something for midterm, and then longer-term objective. So show some results initially, quickly, then build on that, and then don't lose sight of your longer-term objective. So that's, I mean, it's an abstraction. I'll have to think of an example. Well, let's say low-hanging fruit. Shorter term could be a Wolfgang's model. For a short period of time, start developing relationships, and then build institutions for the longer term in those areas, in those countries, which might not be open to longer term relationships and wait for 10 years to see the results.
Thank you, Javed. I would say that there are not that many barriers to creating international partnerships. It's fairly easy to sign a memorandum of understanding. In fact, we at Weill Cornell have a lot of MOUs that really haven't gone anywhere. And the reason that the problem isn't that we couldn't get the two deans to sign the affiliation agreement. The problem was there wasn't a strong desire in the institution or within the faculty to actually do the legwork necessary to create a long-term collaboration. Many times what these come from is a researcher wants to collaborate with a researcher, and so you develop this collaboration, but it doesn't go any farther than that. All they do is share their research. They don't involve their students. They don't involve people in other departments. They don't exchange, faculty, et cetera. So really, there's not so many barriers to creating them. They're fairly easy to create. The barriers to creating a successful long-term one is it probably needs to have multiple levels of interface. There need to be students who go. There need to be trainees who go. They need, or not necessarily go, but collaborate. There needs to be a real fit for the institution that wants to actually provide, care in that region, and the region actually is interested in having care, come from that region. There's some natural geographic, partnerships which occur with in different parts of the world. There's sort of natural collaborations which occur. So the issue really is finding a partner where there's going to be enough points of connection that it will survive one or two people losing their research grant or leaving the institution or something else. There needs to be this desire that there's multiple levels of connectivity, so it doesn't rely on one person, at least in my experience, because we've got a lot of successful partnerships, but quite frankly, we have a lot of signed agreements that right now aren't bearing any fruit because they were too dependent on a single personal relationship and not about a connection between programs. Does any other panelists want to comment on that question about barriers to international collaborations?
I have a question for Rob in particular, because Rob, this is, unless it's proprietary information, I'm very interested in how you guys came up with a model of helping the Cleveland Clinic in Abu Dhabi to really operate. We have a similar example, but we have not used that model. I'm talking about Sidra here, which is owned and operated locally. But how do you come up with a model where you are not really owning any aspect of it, but just operating from a distance? I mean, exactly how does that work?
Trust. So when you say operating from a distance, our current CEO, Tom Mihaljevic, was the CEO of Cleveland Clinic Abu Dhabi for 6 years. So there is, all of our clinical leaders in Abu Dhabi are from the clinic, or at least spent time with us in the U.S. here. And so it's not a branding exercise at all. I was on the flight when I was, as the CMO, probably on a monthly basis, back and forth, trying to shepherd that cultural exchange, the value exchange, and the trust. Once the trust is broken, it takes years to get it back. Because what is healthcare? What is a healthcare brand? It is a substitute for in-depth knowledge of what you get when you put the IV in your arm. All the input that it took to make sure that medication is the right medication delivered in the right way, the trust is in the brand of Weill, Cornell, and New York Presbyterian and Cleveland Clinic. But that's predicated on making sure that you're a good steward of the relationship. When we first got involved over there, there's a huge ramp up in our internal cost. And our local partner said, you're at a fraction of where you need to be as far as internal expenditures to justify this relationship. And that trust said, well, that's because we're so early in it. When it gets to actually the opening of the hospital, we're going to be over our expenditures by far. We know that, and we're in this for the long term. So therefore, the establishment of that relationship, how long the contract is for, what the shared incentivizations are, what the milestones are, they have to be laid out early in that exchange of culture and values, because you will not have sustainability. And you know better than I know how many people have come and gone, right? It's always like, they started out strong, but things then turned sour. And how do you build that sustainability over decades? That's what we're talking about.
Thank you.
Thanks. So there's another question here, and the question reads, does high tech and high touch also translate to greater access to healthcare? That's a complicated question, but it's a good question that I think we should address. So high tech and high touch and access to healthcare. I'll start with Lisa Newman on this one, but be thinking other panelists about that issue.
The question is terrific, and it's a question that can be posed regarding these international global partnerships that we've been discussing, and it's a question that's very relevant right here in the United States with the horrendous disparities that we see in health outcomes related to populations of different racial ethnic identity because of differences, the egregious inequities in the distribution of wealth, educational opportunities, professional opportunities. We unfortunately do not provide equitable health care to all communities here in the United States, and we see these same inequities magnified when we start looking at international populations. So all of these same maneuvers, strategies that we've been discussing in cultivating international partnerships are relevant here in the United States. You do need to have strong relationships with community-based organizations in diverse neighborhoods, diverse communities. You need to have the trust of diverse patient populations so that the healthcare is utilized appropriately. And we need to invest in the training of a more diverse workforce. We're talking about investing in the training of the healthcare professionals in international countries, low and middle income countries. We need to make that same investment in the younger, diverse generation here in the United States, because we do need a more diverse workforce that will definitely deliver better healthcare to our diverse patient population.
Thank you, Lisa. Yes, we in the U.S. should be very careful not to preach about healthcare equity and healthcare access, because while we have a tremendous healthcare system for those who can access it, we have major issues with getting the quality care to all of our population. So, shame on us. I think that part of the issue there is that, quite frankly, we don't have a healthcare system in the United States. What we have is a crazy hodgepodge of all kinds of different state, local, private, public, federal, reimbursement and organizational models that are bewilderingly and unnecessarily complex and duplicative. At its best, it's really good, but unfortunately, we don't provide that at its best across the U.S. Despite the fact that we're a pretty smart country, we do things pretty well. Healthcare, we could do a lot better, and it's going to lead to another question, which we've got in just a minute. But I want to get other thoughts on this particular question. Wolfgang, I know you were smiling and nodding, but when I read that question.
Oh, yeah. Well, health is a global issue, but the healthcare systems, they are not the same globally. And therefore, I'm coming back to what I already said before. I think we should focus on the individual. And the individual, I mean the physician, because the physicians globally, they have sort of a similar interest to help their patients make them healthy again. And I think we should capitalize on this global mentality of physicians. This is, in my view, the secret. And we can go from there, because a collaboration between two institutions is difficult. I think actually that the Weill Cornell Qatar and also Abu Dhabi are two of these very few examples in the non-for-profit world where it really worked. But even in Qatar, there were problems with Hamad, because the university and the people who were backing that project, they also faced an opposition with the Hamad, with the hospital organization. But you know much better than I do. But there were some hiccups at the beginning. But you are a great diplomat, and you managed to build that university. And today, yeah, it's a monument. It works. The same is true in Abu Dhabi. And I know, by the way, Thomas Mihaljevic, as I told you, he was the course director of our first cardiac thoracic surgical seminars, but he built trust. But that's difficult. But individuals find trust much quicker and faster. And it is so much easier for me, for example, to call a colleague. Just take the phone, make a phone call. And how are we going on? What is the next step? And we can arrange that. And therefore, I think it is important in order to have such collaborations growing that the institutions allow these individuals to collaborate and build something. And the more you build, I'm sure the more successful projects will come out. I'm not talking about all the political, religious, and cultural differences, because they are also playing a major role. And the other thing that I believe that it's crucial for a successful collaboration, always start with a not-for-profit initiative. Get the money out of the way. Start philanthropically. Everything can develop out of that. But these are next steps. So I think the people are, and the physicians worldwide, because this is a global phenomenon. Doctors want to help others.
Thanks for those thoughts. I do think that to some degree, high tech combined with high tech is going to increase healthcare access. I think that artificial intelligence and things along those lines is going to be a way that people don't have to stand in line to see one of the only doctors per 50,000 in some parts of the world to actually have their screening done. So I think that used wisely, high tech should actually increase access and screening and accuracy of some things. So I think that that's actually something that is a laudable goal in developing the technology, is not just to help those who can afford it, but to actually figure out ways to use the technology to improve healthcare access, equity, and some level of care in particularly populations where there's significant population demand or significant workforce shortages. So I see that as an area that's potentially ripe, and potentially on a per capita basis will be a much less expensive way to provide some kind of screening and other kinds of services. Now, some things you can't provide technologically. Some things are going to require a high touch, and you have to have both. But I think actually there is an opportunity there. It's not necessarily being developed in that way, but I think thought about cleverly, it could be done that way. There's a question that came in asking, obviously from someone from the United States, saying, does our lack of a national healthcare system hurt us when working in areas that have them? And I would say that I'll welcome other thoughts on this, but I would say that in reality, I don't think it does. But I do think that anyone who wants to work internationally needs to take a class on comparative healthcare economics. You just need to understand the different ways that healthcare is financed in different parts of the world. I think many Americans actually think that every place around the world works like Canada, for example. And Canada has a national healthcare system, and it has a particular way that it finances healthcare. China is not the same as the UK. And for example, many people would say Germany is an example of a national healthcare system. But in fact, the German healthcare system is basically 15 different regions, each of which have their own regional health insurance company. So actually, everybody in Germany has private insurance that is sort of supported by the government. It's not the same as what happens in the UK or in Canada, et cetera, et cetera. So there are, there's the beverage model, and there's different ways that healthcare can be financed. I think if you're going to do international collaborations, you need to spend some time learning about what really are the different models that are out there, which ones are truly central government based, which ones are semi-private, which ones are hybrid. You look at a comparison between, let's say, the UK and Hong Kong, which has its own very unique situation, which is kind of like the UK, but has very different proportions of private and public care side by side, taking care of the exact same population of people. I think it is definitely, I don't know that our lack of a national healthcare system necessarily hurts us, but we need to understand our own delivery models, and really to do international work, you really need to understand that it is not one size fits all, and that there are a variety of different healthcare financing models out there. And there's a variety of different pricing that's out there. The per unit price is so dramatically different in different parts of the world, even with the same healthcare delivery models. There are some places that they just manage to provide, even with private systems, healthcare for dramatically less per capita cost. And that's decades of evolution of the healthcare system in those countries like India and Costa Rica and places like that, which actually are quite busy with medical tourism. People actually go there because they could get certain procedures for less cost per capita, and their systems have evolved to support that based on salary structures and cost structures and other things along those lines. But it's not one size fits all. It's very important to learn what is actually in the country that you want to collaborate with. So, and that is an important consideration. And certainly we don't want to go, we in the United States don't want to go to the rest of the world and say, let me tell you how we do it here because it's so perfect. There are aspects of the American healthcare system which are terrific, but boy, there's things that we should absolutely do better that we could learn from the world on. So, and I'm not talking about Medicare for all or any kind of a thing like that. It's not a political statement. I'm saying there's just a lot of things that we could do better in the healthcare system in terms of equity, cost, duplication, et cetera. But one more question that has come in, which is, how can we respect and manage student expectations in regard to training, specifically teaching the most modern teaching techniques and avoiding brain drain versus country appropriate techniques. So when you're teaching students in different countries, how do you address that particular issue related to training? And I'll start with Javed on this question.
Sure. So it's a very good question, very meaningful question. In fact, I would say there's no cookie cutter formula to do that. However, one has to keep in mind, especially these days, that the information is very widely available. The aspirations are very high, almost everywhere. To then bridge the gap between where the aspirations are and what is relevant to that culture and that country is really something where, to me, is the last mile. That's where you achieve success in having an ongoing, constant negotiation there, because you know that unless the training is relevant to what the problems or concerns of the country are, it's not going to work in the long run. Yes, they will view it as a trophy initially for the first 2-3 years. Ultimately, if it's not relevant, then it's not going to work. So I would say that's an ongoing conversation. We had that conversation here, ultimately, successfully. Initially, there were impediments, and I think they understood, our sponsors understood, that we needed to become more relevant. And as I jokingly say to our faculty, if you want to an island, then you're waiting for the next storm to be blown away. Have very deep roots in the community, really. Become of that culture. Do things which are going to help the culture. And from there on, you can help the rest of humanity. But start there. Charity always begins at home. Make it relevant. Ongoing discussion, ongoing conversation.
Thank you, Javed. And this has come up many times. This has come up. Lisa's brought this up. This came up in the discussions in Tanzania and Haiti. Wolfgang's brought this up. Rob's brought this up. So this is clearly a theme which is coming out. Lisa.
Yeah, I actually just wanted to give a shout out to our younger generation of physicians, trainees. I applaud these kids. They have such an a sincere, wonderful desire to be involved in global medicine, global healthcare. And that's another added value to these international partnerships. It's allowing us to cultivate a stronger workforce in the future, because the younger generation is looking for opportunities to be involved in global medicine, and we have to make those opportunities available to them.
Yeah, I agree. I'm continually in admiration of the current crop of students and the non-self-serving, the selfless goals that many of them have taken when they went into healthcare, and how they really do. They want it to be not a business, but a job. But not a job, but they actually want it to be a calling, and they're actually really passionate about what they can do to help and how they can give back. And they're volunteering before they even know what to do. They're volunteering to help. So kudos to our young trainees. I'm very optimistic about the future of medicine based on that. So I want to thank my panelists for the all day, but particularly this particular group, Wolfgang, Javed, Mohammed, Rob, and Lisa. Thank you so much. This has been really helpful. Each of you has brought a very unique perspective to this discussion about the future of international healthcare. Thank you all for participating in this. And perhaps we will have, I just got a message here that we have over 230 on our seminar today. So thanks to everyone for attending, but thank you very much, panel. And I want to now introduce a brief video. This is a bit of an advertisement, but frankly, I think this is nice to show. I referred to it earlier today in terms of some educational opportunities, which we are working on here at Weill Cornell in collaboration with Cornell, which is a very well-established organization. So thanks again, panelists, and I'll ask now to show the video, and then we'll come back for some closing comments.
In today's accelerated world, the need for cutting-edge medical education and training has never been more urgent. What if you had a way to help physicians, advanced practice providers, and healthcare administrators develop the critical competencies they need to grow and drive success? Introducing the Weill Cornell Medicine Virtual Online Institute in partnership with Cornell. your solution for anytime, anywhere, enterprise-wide development, with online content developed and delivered by top faculty at both Weill Cornell Medicine and Cornell University. Whether you're looking to fill knowledge gaps, improve care delivery, or develop the next generation of leaders, On Demand offers the ability to develop custom learning pathways to meet the specific needs of individuals in your organization. Choose from hundreds of lessons on relevant topics that connect to your most pressing opportunity areas, including subspecialty content, advanced patient care techniques, and strategic planning. In addition, your access will include eCornell's library of content, with topics such as professionalism in medicine, healthcare administration, cardiology, change management, and more. Through bite-sized video content and self-paced lessons, the Weill Cornell Medicine Virtual Online Institute connects the learning directly to each individual, yet scales across your organization. Learning programs are supported by dedicated eCornell learning consultants and offer blended learning guides that can help you facilitate team discussions on each lesson to contextualize the learning to your top challenges. These blended learning guides allow for one-to-one mentoring and coaching or large-scale learning sessions expressly tailored to your needs. Organizations everywhere are using On Demand from eCornell as a flexible enterprise-wide performance support tool, whether as a standalone solution or a way to augment current in-house programs and initiatives. The lesson libraries can be integrated into your company's LMS or learning experiences platform, or delivered through a Cornell online platform. Inquire about how the Weill Cornell Medicine Virtual Online Institute can transform your workforce today.
All right. Well, thank you all very much. I want to thank all the attendees who attended our inaugural symposium today. I hope you enjoyed it. We certainly enjoyed having the discussion, and hopefully this is the first of several conversations we will initiate going forward. I want to thank all of the panelists who participated today and gave their time voluntarily to share their thoughts. I think we learned a lot from people who are real leaders in international healthcare education and research. And I want to thank them very much. I also want to thank, again, the staff here at the International Office of Weill Cornell. That's Dr. Jim Pellegano, Monica Shaw, and Brian Lay. They have been incredibly helpful in helping to put this on. We did have one more slide, Chris, of the contact information for our International Affairs Office. Do you have that, or do you want me to share that? Do you have it? Yeah, so we will put up the contact information for our International Affairs Office, and feel free to reach out. We would love to hear your feedback about this seminar, other things that we would potentially cover in the future, or other things that you'd like to talk about. But again, thank you for spending your time with us this morning, this afternoon, or this evening, depending on where you are in the world. And we look forward to future collaborations. And I want to thank the team at eCornell also for helping to orchestrate this panel with videos and slides and multiple panels and speakers. I think they did a great job, and we look forward to continuing partnership with them. So thanks, everyone, and we will sign off here and enjoy the rest of your week.